My name is Bob Benson. I'm the chair of the Integration Joint Board for Perth and Kinross, and I welcome you to our meeting on Wednesday, the 20th of September 2023. Item 1, do we have any apologies for today's meeting, Scott?
Thank you, Chair. We have apologies from Maureen Summers. I'm not aware of any other apologies unless anyone wants to let me know at this stage.
Thank you very much indeed. Okay. Item 2, declarations of interest. Any declarations? Thank you. Item 3, minute of meeting of the Perth and Kinross Integration Joint Board of the 21st of June for approval. Can I have any comments on the accuracy of the minute before we move to approval? Okay, then I'm assuming that the minute is correct. Can we now move to approval? And I'd like a proposer and a seconder, please. Do we have anyone in the room, Scott?
Yes, Bob. We've got Councillor Illingworth and Martin Black are proposing and seconding, so that's agreed.
Thank you very much indeed. That then takes us to minute approved. Then item 4, action points update. Is this Mrs. Pepper's going to do this one?
Thank you, Chair. Yes, I'm happy to talk through that. There's one action point, which is reference 142, about holding an IGB development session on primary care strategies. We have a timescale identified for the 29th of November, but I'm mindful of the fact that you may be aware that the lead partner, who's the Chief Officer for Angus Health and Social Care Partnership, is retiring at the end of November, and we would probably benefit from their contribution, and also that there is a new operational medical director who's recently been appointed, so we may have to adjust the timescales accordingly in order to have support from our primary care services team and the NHST side.
Thank you very much. Does that suggest, Jackie, that we bring the meeting forward before Gail Smith retires?
I'm not sure if that's going to be possible, but we'll try our best.
Right, thank you very much. And it would be good if we could find out what the interim arrangements are once she retires. Thank you very much indeed. Thank you. That now takes us to matters arising. Jackie, I think you wanted to say something about Medvin as a matter arising.
Thank you very much. Really just to say that following the information that's come to the IJB about the Medvin branch surgery, we are on track to bring a report back to the Integration Joint Board by the 29th of November meeting. There have been responses received in relation to consultation and responses through community meetings, and that's being collated currently. Members of the Health and Social Care Partnership Management Team and Primary Care Services Support Team are involved and continue to be involved with discussions with the practice and primary care services, and are currently engaged in discussion around potential options. So we're on track for a report to come back to the IJB at its next meeting.
Thank you very much indeed. Any questions or comments for Jackie? If not, I'll move on. Okay.
Sorry, Chair. I think Councillor Stewart wants to come in.
All right. Thank you, Colin. Please.
Thanks. Yes, it's a matter arising from our discussion on the primary care premises strategy. and the consultation that's ongoing on that. It was just to ask whether there may be some residents of Perth and Kinross who are excluded from completing the consultation. It was came up at a council committee last week, and I just wondered whether there was an update on that, expanding it to make sure that all residents can answer the questionnaire.
Thank you, Colin. Colin, just to clarify, does that mean there are some patients who are out with our area but still use local GP services in Perth and Kinross?
Well, it could be in that direction, or it could be residents of Perth and Kinross who use services outside but may have transport issues getting to and from, or access issues and so on.
Thank you very much indeed. Who wants to take that question?
I'm happy to address the question that Councillor Stewart has raised. The primary care premises strategy for Perth and Kinross, as you know, was launched on the 11th of September and will close on the 15th of October. And it's primarily aimed at patients who are registered with practices within Perth and Kinross. So I've raised that with our team in relation to the survey itself, because I believe you have to indicate that you are a registered patient with a Perth and Kinross practice before you can continue to proceed with the survey. And I suppose if you were registered with a practice outside of Perth and Kinross, there will have been an opportunity to engage in any consultation that might have been carried out. For example, we know that Dundee have already carried out their survey. But if there's anyone who wishes to contribute to and present their views, then we'll find a way of addressing that, Councillor Stewart. But the consultation is live, and we know that we've already had 1,000 responses already, which is pretty healthy in the first 9 days of the consultation. But we will try and address that question. Thank you.
Okay, thank you very much. And Councillor Frampton, I'm glad you've been able to join us on sound now. Thank you. Okay, can we now
Chair, I think
move on?
Councillor McCall wants to come in with a question or a comment.
Okay, thank you very much. Councillor McCall.
Thank you. It's really just a follow-up to Councillor Stewart's question in your reply, Jackie. A number of residents of Perth and Kinross have transferred to Dundee practices because of the situation in Invergowrie, and I think it wouldn't be fair to have them excluded because they weren't registered with a practice in our area.
Do you want to take that, Jackie?
Yeah. Yes, thanks. I asked Lisa Milligan, the Primary Care Services Manager, about that particular issue, because it was of a concern, and the response that she's given is that those patients were registered with the GP providing the Ancram practice, so they would have been considered in the Dundee consultation. That's my understanding. You don't think that's the case?
I think it's a big gap, given the paucity of GP services and premises and the whole of the Karst Gowrie, that residents there are not able to represent their views to this particular survey for Perth and Kinross, and possibly similar for people in, you know, sort of Amid and Erne sort of direction if they're going over a county line as well.
Thank you. Jackie, is that something you want to take away and think about? Thank you.
Yes, that's the response I was going to give, Chair, that I'm hearing the concerns that are being raised, and we'll take that forward with the team to see how that can be addressed. Thank you.
Okay, are there any other matters arising? No. Right, thank you very much indeed. That then takes us on to item 6, which is membership update.
Apologies, Chair. We've just had a further request from Bernie Campbell for, I think, another matter arising.
All right. Thank you, Bernie.
Apologies, it actually doesn't have anything to do with matters arising. I can't get onto the internet to access the papers. If you could give me the password or give me an idea why I can't do that, it would be great. Thank you.
I'm sure we'll try and help you as best we can, and hopefully you can get connected as quickly as possible. Okay, Scott, do you want to take us through the membership update? And I believe that you'll be following up this in writing, is that correct?
Yes, Chair, thanks. Just a update for members in relation to membership. First of all, to do with the position of Chair and Vice Chair. In line with the integration scheme for the IGB, the position of Chair and Vice Chair rotates again between Perth and Kinross Council and NHS Tayside on the 4th of October. Perth and Kinross Council have decided that Councillor Colin Stewart will take up the position of Chair, and NHS Tayside have nominated that Dr Jackie Jensen will take up the position of Vice Chair. So these appointments will commence officially on the 4th of October. Dr Lee Robertson from NHS Tayside, who's a non-voting member of the board, their current term has expired. She's indicated a willingness to be reappointed, and this has been supported by NHS Tayside. So the board has asked to formally agree that Dr Robertson be reappointed for a further 3-year period.
Do we want to take that one first, Scott, and then move on to the next one? Do we approve Dr Lee Robertson being reappointed to the board? Yes, I seem to get general acquiescence about that. Scott, next one, please.
Thank you, Chair. Sandy Watts is the current third sector representative on the board, whose also term officially is coming to an end. The third sector forum are due to discuss third sector representation on the board in due course. So for now, the IGB are asked to formally agree that Sandy's membership of the board be continued until the outcome of these discussions and we hear any further update from the forum.
Can we concur with that? I think so.
Thank you. And finally, in relation to both the 2 carer representatives and the 2 service user representatives on the board, their 2-year appointments are coming to an end. Similarly to previous practices, we will have elections taking place that will be initiated and supported by various organisations such as Carers Voice, the Reference Group and the Community Engagement Team. The process, timescales and proposed terms of the length of the appointments on the board will be determined as part of these discussions. So until such time as elections can take place and are reported back to the board, the IGB are again just asked to formally agree that the current public partners, Sandra, Ian, Bernie and Maureen, have their membership formally extended for this period. Again, the board are just asked to approve this outcome.
Does the board concur?
I'm happy if there's any questions or comments on those particular
Sandra, do you wish?
aspects.
Sorry, Sandra wishes to come in. Sandra?
Yes, so thank you very much for that update, and the correspondence leading up to that has been very helpful. Could I ask a related question regarding public partner involvement? I wondered if it was the intention of the executive group, so chair, vice chair, chief officer, to restart the meetings which had been regular with public partners. They seem to have sort of fallen into abeyance a little, and they were extremely helpful. And whilst understanding pressure on diaries, the desire would be to restart this from our perspective.
Thank you, Sandra. I think probably I'd say to the next chair is that he takes up that matter with the vice chair, because I think it's been very productive to date. But obviously we're being asked to vote today on the continuance of these current appointments, but your point's made. Does everyone concur with the arrangement that Scott's outlined? Okay, I'm not seeing anything else. Thank you very much indeed. Are there any more updates, Scott?
No, Chair, that's all of the membership updates.
And you'll be writing out to that effect around the board, just for clarity for those who may not be around today. Thank you very much. That now takes us on to item 7, delivering on strategic objectives. 7.1, Chief Officer Strategic Update, Jackie Pepper.
Thank you very much, Chair. I'm just going to address 3 key areas to provide an update and information to IGB members, one of which we've already covered, which is the primary care premises strategy and the survey that associated with that. So I'll come to that at the end. But the first area I would like to alert you to is that in August, the Health and Social Care Partnership, with the support of Perth and Kinross Council's HR colleagues and a lot of work, I have to say, by our own Kenny Ogilvie as interim head of adult social work, were successful in becoming one of, I think it's only 2 local authority areas in Scotland that will be a core pilot for international recruitment into the Scottish adult social care services. So we are one of 2 local authorities as part of that pilot, and we received just under £80,000 of Scottish Government funding to support this. So that's welcome news. We will be expected to create a local infrastructure to recruit to the vacancies that we have and onboard new recruits through induction, accommodation support, pastoral care, and all of the support that people coming from overseas will require. So we're working through what that will look like and how that will be delivered in partnership with other services such as our housing colleagues presently. So that's good news on that front. The second area is that we have, as a Health and Social Care Partnership management team, been in discussion with Councillor Massey of Perth and Kinross Council. Councillor Massey is the older people's champion for the council, and he met with us to consider the possibility of seeking accreditation with the World Health Organization to join the global network for age-friendly cities and communities. And IGB members will be familiar with our demography and geography and the priority that we give over to older people within our IGB strategic commissioning plan, and also familiar with the challenges associated with a growing older population. And we know as an IGB that requires a whole system and whole community planning approach and infrastructure to be successful. And to mobilise contributions from all partners. So accreditation with the World Health Organization and the UK membership of the UK network would provide access to the latest research, evidence-based programmes, knowledge and best practice across the world in terms of healthy ageing, and would bring some international recognition. So we've agreed to work with Councillor Massey to support the application process, and that's timely in the sense that today we have our first update report on our older people's strategic delivery plan. And I hope that the IGB will endorse this proposal and seek an update from me in November on the progress that we've been able to make. And the third area was really just to give you an indication about the success of the so far of the survey in relation to the primary care premises strategy. The consultation is live, has gone live from the 11th of September and will remain open until the 15th of October to enable a better understanding of how patients view their local GP practices or health centre, and aid planning for future service provision. And we've already received 1,000 responses, and not to be competitive, but that's already 2.5 times the total number that Dundee received during their survey. So if we keep that up, I think that's a significant response rate, and that the detail of that when it's reported to the IGB will give substantial evidence of what our patients across Perth and Kinross's views are. So thank you for that.
Okay, any questions or comments for Mrs. Pepper? Any in the room, Scott?
Sorry, Chair. I think Martin has a question.
Martin?
Well, that's the first one first. International development and the £80,000 being awarded. Can you tell them what international means? Because does it include European?
Can you clarify that question? I always assumed that international meant international, but I never realised that it would have excluded Europe. But anyway, who can answer that one?
Yeah, I can come in, Chair. Yeah, international obviously it means international and it includes Europe. There are certain rules from the Home Office regarding actively engaging in recruitment campaigns, and we're restricted to actively recruiting in what are termed as green countries, and there are a number of countries on the green list. That said, if we advertise online, we can accept applications from anybody from anywhere in the world, but we can't actively recruit in any country that's not a green country.
That's exactly why I asked the question, because international with caveats. So maybe you need to recognise that international means international usually, but in this case it means international with caveats.
Okay, thanks for that helpful question, Martin, clarifying that point. And Kenny, you think you can take that away and find out what exactly who is not on that list, if you can. Martin, did you say you had another question?
Yes, I did have another question. Thanks, Chair, and it's about the accreditation. I think that's wonderful that we're doing that. That's absolutely first class. But do we also think in the future that we need to link how we're going to support the older people as they get older? There needs to be an accreditation. There may be young people or a link towards ensuring that will go forward.
Sorry, Martin, can I just clarify that part about younger people? Were you suggesting that other characteristics should be included as well as older people?
I'm saying for every action, Chair, and if there's an accreditation for older people, then that creates a reaction or it creates an action. And what I'm asking, is there anything in place for us to look at how we're going to support the accreditation for older people? It's great keeping people older, but if you can't feed them later on, it's not much a win.
Okay, Kenny, I'm going to ask if you can pick this up.
Sorry, I'm not entirely sure I understood the question. I mean, certainly if you look at intergenerational work is part of the age-friendly communities. And one of the advantages of the age-friendly communities, you know, it takes a sort of whole system approach. I mean, obviously in the Health and Social Care Partnership, we do focus a lot on the sort of heavier end in terms of hospitals, care homes, care at home, etc. Although, as we will come on to with the presentation for the older people's strategic delivery plan, there's a lot of early intervention work going on there in that as well. But again, it's very much a wider approach for the age-friendly communities, and you look at accommodation, transport, etc. Employment, healthy lifestyles, and like I say, intergenerational work is included in that as well.
Really sorry I'm asking difficult questions, Chair. I'm not difficult in my tiny head.
It's okay, but it's fine because obviously you've raised the issue and the officers will go away and just consider that further. They may not be able to give as full an answer as you would want today, but it's something that you've raised, so therefore we'll keep that on our agenda, I think is what I'm picking up from Kenny. Okay, right, thank you very much, Martin. I've got a comment from Sheila McCall and then a question from David Illingworth.
Thank you. Martin, this might help set your mind at rest just a little bit. Although obviously we're working with the Health and Social Care Partnership, I fully expect this to come a future council for a motion for approval in some shape or form, because it's not just about health and social care, it's about the whole built environment, it's about social environment. So all of those aspects I expect will be considered, and a lot of the, as Andrew sits in the Public Health Committee, knows a lot of the delivery of public health and, you know, public health improvement sits within the council remit. So this will also be coming at some point to council for its approval and support.
Thank you, Sheila. That's really helpful. Thank you, Sheila. That's really helpful. Just out of interest, Sheila, which council committee deals with such matters?
You mean this motion?
Yeah.
This will come to this would come to full council for its agreement across all of all councillors.
Okay, right. Thank you.
So it's a bit like the smart cities, that, you know, eliminating HIV, that came to full council for approval. So that's where they come.
Thank you for that. Now I see that David's question has already been answered by Kenny. So I'm looking in the chat box and I don't see any further questions at the moment. Any further questions before we move to the next item? Okay, right. Thank you very much, Jackie. That now takes us to your next stance as well. 7.2 Tayside Mental Health Services Strategic Update. Jackie.
Thank you very much, Chair. I'm pleased to say a few words to introduce this report, because it's a very high-level progress update since the last report came to the IJB at the end of June. And it sets out the commitment to the ongoing collaborative leadership group and the programme board, which have continued to meet. And the programme board meets again next week and will receive a detailed progress report across the whole change programme. A key point to note in the report is that the Minister for Social Care, Wellbeing and Sport, Miss Marie Todd, met with members of the Tayside Executive Partners on the 24th of July. I think she's due to meet with them again before the turn of the year. The meeting was very positive. The Minister acknowledged the pressure that has been placed on Tayside as a result of ongoing scrutiny for a considerable period of time, and providing an offer of support to ensure that the system is self-scrutinising and focused on continual improvement. So it was a very positive meeting, which ended with an offer of support, which we have since taken up through 2 further meetings with Scottish Government advisors and officials. The programme board received a comprehensive updates on 2 of the areas of redesign, which is priority 1, adult inpatient redesign, and priority 12, the specialist community mental health services redesign. And it's anticipated that that will form a core part of the programme for the development session that's been planned for the 31st of October now, and all members of this IJB, the other 2 IJBs and NHS Tayside board members should have received a diary hold for that date. It's also anticipated that the first design thinking workshop facilitated by experts at the V&A Museum will bring together the three interrelated areas of redesign. That's the adult inpatient redesign, the specialist community mental health redesign and crisis and urgent care, and bringing that together with a whole range of colleagues, including Scottish Government advisors, to develop an integrated or a continuum of support and new models of care together. And the dates have been agreed for that, and that's in the week beginning the 23rd of October. So hopefully there'll be some update at the workshop on the 31st of October. And I'm happy to take any questions from members.
Thank you, Jackie, and really looking forward to the event on the 31st of October. I'm going to take Jackie Jensen and then Councillor Stewart. Jackie.
Hello, Jackie. Page 15 of your report on it's priority 2, and it talks about it's about priority 2 or phase 2, and 3.3 talks about the development of a financial recovery plan. And I note that those meetings were happening this month, and we'll probably get an update on that on the 1st of October. But one of your priorities, priority 10, talks about requiring a revision of milestones, and priority 11 talks about requiring a revision of milestones. And I'm wondering if that revision is related to the financial recovery plan not quite being in place yet.
The quick answer to that question is actually it is not. It's really a revision of early stages of the milestones that were set out, not the completion dates. I hope that gives you some assurance there.
Thank you.
Okay, thank you very much. Councillor Stewart.
Thanks. My question's in relation to the design thinking workshop, and I was just wondering who are the participants of that workshop, and what sort of external expertise in terms of patient service users and so on there is, or is it a solely professional at this point?
In terms of the design workshop, there will be professional expertise from the work streams and the work stream leads, but each of the work streams has actually members with lived experience, and we'll also be seeking representation from the programme board, specifically from people who have lived experience. We've invited a number of other participants to the final day, which will include, for example, organisational development, HR, finance, etc., and have invited the professional advisor, clinical advisor in psychiatry to the Scottish Government, and he said he would be quite happy to come along to the third day. So the workshop and that first workshop will include all of that. Councillor Stewart.
Just to come back in quite quickly then, it sounds like that's quite professionally biased rather than in terms of the users or lay people. You know, you were talking about all of the sort of professional supporting OD, HR, finance, and then the clinical advice from the Scottish Government and stuff like that. It sounds like it would be maybe more focused on design for the system rather than for the patient. Just a concern.
Okay, Jackie, do you want to respond to that?
One of the ways in which the design thinking workshop, one of the principles behind it is to allow that redesign to happen, but to enable a whole range of others to come in and challenge that, support that, ask questions, and inform it as part of the development. So that's part of the programming.
And presumably, Jackie, that we'll see more information about some of this at the meeting at the end of October, correct?
Yeah, I'm hopeful that the emerging thinking will be at a mature enough level to be able to visually present that to everyone on the workshop on the 31st of October.
Thanks very much, and it gives us another opportunity to input into that process as well, Councillor Stewart, I think. Okay, have you any more questions, Colin?
No, carry on.
Okay, thank you very much. I've got Sheila McCall, and then I've got a question from Martin, and then Sandra Auld.
Thank you, Chair. I share Councillor Stewart's concerns about lay people being involved, particularly for those who get support for independent living, those with learning disabilities in particular, because very often their voices aren't necessarily heard enough. And I just want to, so I just want to endorse what the points that Councillor Stewart has made. But I just want to check, when you talk about community mental health services, is that outpatient services?
I'm going to ask Christopher Lamont, who is the Senior Service Manager for mental health and also the lead for our community mental health strategy. So Chris, and involved in that particular work stream. So do you want to say something about that, Chris?
Thank you. My microphone doesn't seem to be working. Thanks, Chief Officer. So our community mental health teams do include outpatient appointments, Councillor McCall. So we're looking at community mental health teams, we're looking at our learning disability services, we're looking at our integrated substance misuse services, and all of that encompasses both home treatment and outpatient appointments within a hospital environment. So yeah, it would encompass all of those.
Sheila, is that fine?
Thank you, that's very reassuring.
Okay, thank you very much indeed. Now, a question from Martin and then Sandra. I don't know, Jackie Jensen, is that a redundant hand you have? Thank you.
Get it down.
Okay, right, thank you. Okay then, Martin and then Sandra, thank you.
Thanks, Chair. Too quick. And priority 9 and priority 12 on page 15, we have on track. But there's very little narrative. I could see more narrative in priority 12. I see very little narrative and on track. Can we have more narrative on that? There are plenty of things on track, but they're no moving. Yeah.
Thank you. Thanks very much, Martin. And it was a challenge to consider what level of detail to provide to the IJB here, given that this is the first time that this has been exposed in a public report. And one of the opportunities I think we have on the 31st of October is to think about how and what information and the detail of that information is provided to all of the relevant forums. So hopefully we'll have an opportunity to see what that would look like and ensure that consistent reporting is done in as quick succession as possible to each of the 3 IJBs and to NHST Side Board.
Thanks, Jackie. That's very helpful. I like the report like that. That's helpful. I had a quick second one. I just want to ensure that under 3.3, where it says in recognition of the September deadline, are we sure that that's going to be met?
The September deadline has slipped on that one, in that the financial framework we need to build around the new model that will come out of the workshop. And there's a recognition from our finance colleagues, it's very difficult to build a financial framework unless there's clarity around how we're moving towards that new model over a period of time.
Okay, that takes me to Sandra Auld.
Thank you very much, Chair. So moving on the same theme as Councillor Stewart and Councillor McCall's points regarding lay involvement in this, when I was reviewing the papers for today's meeting, it came back to mind that we had public partners had asked previously if consideration could be given to making the papers more accessible for non-IJB involved as your day job, and this paper in particular, so an example of the lack of plain English being used is, for example, in the proposal section 3 and 3.1, there's a paragraph in there referring to risk, which reads, the strategic risk related to the delivery of the strategy will be replicated in risk registers for all partners, including the Perth and Kinross IJB, as this is a whole system programme of change requiring collective leadership, ownership and management of risk and mitigations. So I just feel that language like that doesn't make these papers accessible to people who might want to keep track of what's happening. And I wonder if further consideration could be given to making the papers their format in plain English. Is that something that might be possible?
Jackie, if you want to respond to that question.
Thank you very much. I think I can certainly take your comments on board around particular technical descriptions and sometimes some of the jargon that we may include in reports. So I'm happy to take that on board, Sandra. I think one of the things that will be difficult in terms of ensuring that our reports are plain English is the timescale and the expertise to do that. So we might want to reflect on what that might look like in terms of how we communicate in advance of and after IJB meetings. But I think the resources that would be required to do that, we don't have that currently. So we'd have to be seeking additional support to enable that to happen.
Thank you, Jackie, and also note Councillor McCall's availability and easy read version as well. I think that probably, and maybe it's just one of the difficulties, because clearly these are reports for the board, and it's how the communication is taking place with the stakeholders who are not going to be able to access that kind of information easily as been raised. And I suppose that comes back again. I was thinking about the same point actually when we were looking at Priority 2 in Strathmartin, for example, about views of residents and patients. I mean, there's some of these patients have been there for a rather long time, so there's a real kind of need to us to be assured that the processes that you're going through will ensure that what Sandra's intent is to make sure they're fully involved and understand what's happening around them is actually clear within the process you're going to undertake. And I think that's a very big job for your design work in terms of consultation, I would have said. But I think that's because I think Sandra's point is a fair one, and having worked historically, particularly in the area of learning disability, you do need to have different kind of processes in some of these areas. Okay, Sandra, I think your point's made, and I hope you're satisfied with the response you've had. But
thank you very much.
Yeah. A lot is dependent on how we actually physically do that in the processes that Mrs. Pepper has outlined. I don't have any further questions or comments online. Are we content to accept recommendations in the paper? Comment from Beth.
Thank you. I'm just going to be a bit indelicate here in the sense that I really appreciate all the points people are making about involving service users and carers, etc. There are certain things that need to be done by professionals and some workshops that do, and I think this process is exceptional in the amount of work it's doing to bring people in to the decision-making process and involved in it. But I still think we need to be aware that there will be some areas of this work that the professionals need to do without all of us interfering, if you like. So whilst I really think it's great that we're doing this, and I think we're doing this more than any other programme I have ever seen, I think we have to be aware that there will be some occasions when there will be meetings that are not the professionals involved in this process would be involved in. And I just wanted to make that comment. So thank you.
Thank you. I think that's probably understood as well, Beth, but thank you for that, because I think it's an important point to make. Jackie, I don't think you need to respond to that unless you particularly feel you need to.
I did want to say something, Chair, if that's okay, and I appreciate your comments, Beth, because one of the things that is in the paper that we haven't touched upon is the new National Mental Health Strategy and the emerging strategic delivery plan that will, or the delivery plan that will follow that, and the Scottish Government's commitment to, for the first time, publishing standards for mental health services. So I think the way in which across Tayside we embrace those standards and we use those standards to engage with people and ensure that they receive the experiences that they're entitled to is actually key to this, over and above what we're talking about here in terms of the model in which those services are configured. So I think there should be more to come through from that in due course.
Okay, thank you, Jackie. And I've got further comment from Ian and from Sheila McCall.
Thanks very much, Bob. Just to follow on from what Sandra said, the problem she outlines is one which across the whole of the public sector is an issue, has been for years. But that's not to say that there's things that we should be looking to do along the lines that she suggests. Is there not an organisation now nationally which gives advice to councils and other people on how to do plain English without disturbing or undermining the professionalism of the report that goes to their committees? Indeed, I think they actually give awards to those authorities who take steps to improve things.
Okay, I'm going to pass that back again. Is that Kenny? Is that someone else there? Sorry, I missed it. Jackie, do you want to just respond to that one? I'm sure there is an organisation, but I can't remember who they are.
No, it's Ian.
Oh, sorry.
I was just going to say there is a crystal mark for plain English that's awarded, and that's something that we can perhaps aspire to and look into. And I'm looking at my colleagues in committee services in terms of enabling us to do that.
Okay then, thank you. Sheila McCall and then David Illingworth.
Thank you. Plain English, in fact, easy read versions of documents has long been a hobby horse of mine, even before I became a councillor. And I do understand that there are resource restrictions within the Health and Social Care Partnership and indeed within the council. However, I do know that certainly around about election time, there are organisations that support people with, for example, learning disabilities to provide literature, and perhaps as part of our engagement, we should be talking to them before, because they will help us and they might probably be quite happy. Well, I would hope to engage and help turn some of this information in. So, because if we don't get the engagement with the service users meaningful and feel that they understand what's happening, they won't use the services, or they won't come to use the services until it's far too late. So, and then they're in crisis, and then they become inpatients rather than, we've been supported in the community. So I think I'm not saying it's easy, but I think it's something we definitely need to try and figure out how we can try and mitigate some of this, at least when we get to the engagement side of it.
Yeah, thanks very much. And thanks very much, Sheila. Of course, that's exactly why we have service user representatives to assist us in that process, as well as what they're saying formally at board level, so we can draw upon their expertise and experience as well. I'm going to move on to David.
Sorry, Bob. I just need to come back to this.
Sorry.
There's quite a skill in developing easy read documentation, and I although I'm here as a councillor, I'm also a carer, and I would struggle to put stuff into an easy read version for different types of communities. I also think I should have said speech and language therapy should be involved in this, because they can advise, and there's different techniques. Some are more pictorial, some are more words. So it's a complex scene, and I don't think it's fair to just assume that the user representatives here would have all the skill sets. They may do, I don't know, but I think it's an unfair assumption to make.
No, I wasn't suggesting that they were actually experts on easy read documents, because that is an area that does have a deal of expertise. but the point's been made. But primarily, the report that's been presented to us today is for this board, and the officers need to take away the kind of feedback as part of the process they're going through. I want to bring in David Illingworth, and then Zoe has a comment to make. Thank you.
Are not free, and they're not always 100% helpful, but so yeah, I'm all in favour of all communications being as clear as possible, because what we're trying to do is transfer information from one mind into another mind, and if we don't do that clearly, then it's going to obstruct our understanding of all the issues. So thank you.
Thank you. And I think Jackie had indicated that corporate services could pick up on some of this as well, because it does have resource elements too. Zoe and then Martin.
Yeah, I think there are two issues. I think there's accessible language and there's easy read, and we have an easy read resource within the HSCP, which is very, very small. We use that to produce easy read materials for our strategic commissioning plan consultation. And I do think arguably that could be expanded upon, because that's hugely useful. But there's something about writing reports that are accessible to people who don't have a learning disability as well. And so I think there's probably two bits of work there in terms of how you produce reports that can be distributed to that wider population, because there's a balance to be sought in there, I think, between the two things.
Thank you, Zoe. Martin has a comment, and then Sally has a comment.
Thanks, Chair. And on that, and I actually agree with the last speaker there that you have to look at the fact that you can have all the standards that exist for easy reading, and it's only applicable if you could read. And then 30% of the population, at least 30% of the population can't read or write, and you're usually the element of the population that are impacting most on the services. So there has to be some form of communication that doesn't primarily start with documentation.
I think that's why the importance of other forms of engagement, I think, are really helpful in those areas for those very reasons. So I'm going to take Sally has a comment, and I note Councillor McCall's comment.
I was just going to suggest, because this is a really interesting topic, and if I'm honest, I think it's far wider than the discussions that we're going to be able to cover within the IJB with the very restricted time, that maybe if this is something that we're interested in, then we should take it forward, but with collaboration. I don't think we've even bottomed out what information people want. Do they want to read the reports? Do they want a summary of what happened? Do they want to be able to attend and join us to be able to see what it is? So I think if this is a piece of work we need to take forward, and I agree, I think it's really important. I think there's a lot of stuff that needs bottoming out first of all before we can make a decision about what we do. And I'd be definitely interested in taking that forward.
Thanks very much, indeed, Sally. And I kind of minded about what Tommy Whitelaw said is about what matters to you. And sometimes it's not about seeing the whole picture, it's about specific things that relate to their own lives. And I think that's something we are constantly mindful of. And one final comment, Sandra, before I move on.
Thank you. So it's just to add a little more detail to where my comment's coming from, or my point was coming from. So prior to these meetings, we circulate the papers via the reference group so that service users can be aware of what topics are coming up and can feed into us and back to us, so that points that we can bring forward are relate to their views. So for them to be able to do that in a constructive manner, the information that's shared with them needs to be understandable. So that's where this is coming from, and so the comments that I'm feeding in have come from service users on the reference group. So thank you.
Okay, I'm going to leave it at that, and I'd like to move to the recommendations within the paper. Do we accept the recommendations? And I also noted Scott Henry's comments about it'd be helpful if this discussion was picked as part of preparing the information for the public partner elections in terms of participation and engagement. I think, thank you, Scott, that's really helpful as well. Do we accept the recommendations within the paper? Thank you. Okay, thank you very much. And thank you, Jackie. And we really look forward to the event at the end of October. I'm quite excited about that. That takes us now on to 7.3, progress against older people's strategic delivery plan. And is that Evelyn and Amanda?
Yes, I think Amanda's got a presentation because it is quite a meaty report, so we felt a presentation would be helpful, Chair.
Yes, I did ask for that. Thank you very much.
Thank you, Chair. Thank you, Chief Officer. And as you've already outlined, I've been asked to give. Oh, somebody putting the presentation up.
Yeah, I can see it.
You can't hear me. Can you hear me?
I can hear you. I can hear you, and I can read your document on screen.
I don't think anybody in the room can see it. Oh, there we go. Thank you. Thank you again. So yes, thank you. I've been asked to bring forward the annual update on the Older People's Strategic Delivery Plan on behalf of Evelyn Devine. Evelyn's on leave at the moment, so hopefully we'll be able to do it justice. Thank you. Next slide, please. So the recommendations within the report are to note the progress to date against the programme of work outlined and funded under the Older People's Strategic Delivery Plan 22 to 2025. Request an update in 12 months' time and endorses the intention to evaluate the impact of the IJB investment in the Older People's Strategic Delivery Plan and for these outcomes to be fed into our new budget setting processes for 24 to 27. Next slide, please. This slide just demonstrates some of the key challenges that we're facing in terms of older people's transformation and the population transformation. The slide shows the data up to 2021, and if you see the red part in the middle going across the slide, you'll be able to see the baby boomers cohort is working upwards through the population and still has a long way to go to reach the end of the slide. The cohort gets more concentrated with time, and what this means for us is we're seeing an upward trend in the population who are 75 plus and projected to continue over the next 2 decades and beyond. Next slide, please. So for us, the key challenges, increasing the population of older people, increasing complexity and frailty, and the challenges around workforce recruitment and retention. Population ageing puts Perth and Kinross in the top Scottish quartile for old age dependency, and the rate of increase has outstripped Scotland as a whole. Older people we see and support are more frail and are more complex, and we have an increase in people living with dementia and or severe frailty of around 20% to 25% every decade increase. Consequently, we have a dwindling pool of working age people who will be available to recruit into services for an increasing older population, while we also have competition from other sectors where the pay is higher. This represents the context in which we seek to respond quickly in a target and person-centred way to support people to live independently at home or as close to home as long as possible. Within the paper itself, figure 6 will describe the impact we've had on the over 75 plus bed days, and we've seen a sustained improvement despite our challenges, and what we're feeling as a team is we're running to stand still. Next slide, please. So what have we achieved in terms of some of our 3 work streams? We have 3 different areas that we're focused on: early intervention and prevention, shifting the balance of care, and optimising capacity and flow. This slide shows our approach to early intervention, where we're intervening early to help people remain physically and mentally active and healthy and live independently for longer. We are participating in live active exercise programmes, which are increasing year on year, increasing our volunteering activity, and we've implemented activity workers in our inpatient areas. If you look to the right of the slide, you'll see our Going for Gold update in terms of our care home approach, which has really been a successful approach over a number of years and includes a range of activities the residents are able to participate in. And this year they were working towards creating the best crown in name of the Jubilee, the Golden Jubilee. The other photograph on the right hand side shows the Blairgowrie Pass for All. So this has been a successful project in terms of implementing exercise stations in Blairgowrie Community Hospital and a new paths which allows our inpatients to get out and about when the weather's good, keep exercising and keep mobile and keep healthy and fit and recover more quickly and get back home. And we hope to roll this out into our other areas around Crieff and Pitlochry and in Murray Royal as well. And I've mentioned the activity workers. We also have an enhanced care home team which are supporting our care homes, and they're working alongside the care homes to work and improve practice around that. I think one of our key areas we need to focus on going forward is strengthening our work around early intervention, coordinating with our public health colleagues and addressing the themes that are within the 3-year public strategic plan. And then, as we've already mentioned, working towards our age-friendly communities. Next slide, please. So in terms of shifting the balance of care, considerable progress has been made towards achieving our strategic ambition of whole system integration on the backdrop of COVID recovery, our rising demography, as I've mentioned, and the complexity. We've invested in an improvement approach with our staff and our teams, ensuring change in practice is embedded, and we're learning from that improvement as we go. We've continued to develop our locality integrated teams, further looking at our integrated bases across our locality sites. So we're progressing that around Blairgowrie and Crieff, and aligning that to the public estate work across our public bodies. We've launched our hospital at home service in mid-August, and due to recruitment challenges in terms of medics, we've been held back a little around our progress, but we now have that fully operational service, and now are accepting patients onto that approach and managing to keep people at home as we intended. We're also developing our urgent care pathways and supporting all these pieces of work with the clinical standards that we would expect across our services. Next slide, please. In terms of optimising our capacity and flow, we've made a huge amount of progress in this area of work, given the challenges that I've outlined already, and the pressure on capacity and flow and the management of delayed discharge delays across our sites. So we've spent a lot of time implementing the work around the discharge without delay programme, which has included new discharge pathways from hospital to home. We've implemented a frailty at the front door approach on the PRI site, and we have a new frailty unit which opened in November. Although the frailty unit is delivered under our acute services, we're obviously responsible for the community aspect of that, and we've implemented a frailty team, a discharge team around that to facilitate discharge and ensure comprehensive assessment for patients coming into the area and back out again. We've also spent a lot of time enhancing the integration of the PRI discharge team and the hub and making improvements around that. So a significant amount of progress in terms of the optimising flow area. Next slide, please. So we've shared with you just some of the service user feedback. Like other services across the partnership, we are on care opinion, and we've received some very positive stories and positive feedback through that. Common words you'll see in the Wordle there: help, lovely, care, time, benefit, social, and there's lots of other ones that you can see that are slightly smaller when you have time to peruse. And we've also left some of the comments in that we've received from through the care opinion site. Probably a significant one just to draw your attention to is the feedback from the Corbenick Camp Hill community, which for those of you know is mainly LD clients, but we do have more elderly LD clients within there. So I think that's quite a positive feedback from through our enhanced care home team. Next slide, please. So our next steps really is to focus on transformation. I think, as I've tried to describe in the paper, is where we've been, where we're going, our rising demographics and the pressure on services and the need to transform now. So within older people services, we have 3 of the big 6, as our chief officer will call them, and the 3 are outlined there in terms of our transformation responsibilities. So optimising independence and quality of life for people living at home, which is mainly focused around care at home, and the developments that we need to enhance around that. Enhancing capacity in our dementia services. So how do we support people with a diagnosis of dementia from admission through to community, through to early intervention, and ensure that that pathway is connected. And then developing a person-centred approach to reablement and rehabilitation. So thinking about how our bed-based supports, you know, and how we get that pathway right from community through into admission and back out again. Next slide. Thank you. So our next steps, we've made considerable progress in year 1 towards whole system integration with the investment that was approved from IJB. We have ongoing implementation of our integrated models of care across P&K and ongoing individual projects that we've been successful in. So we are working quite closely with Health Improvement Scotland around a frailty project. We've worked with NHS Tayside around quality improvement projects. So what we're doing is just consolidating all that learning from year 1, and then what are we taking forward into year 2 into our budget review. We're also developing training on the equality impact assessment process to support all our staff and our leads to make equitable decisions and make sure that that's threaded through all our projects and our approaches when we're redesigning or transforming. But I think primarily our next steps is to really evaluate where we are, move forward, and allow us the capacity to create the capacity to focus on the transformation programmes going forward. Thank you.
Chair, there are a few
Okay.
questions in the room. I think you,
Yes.
you may not be able to
Okay.
see that because the presentation's still up. So I wonder if we could take that down.
Thank you very much indeed. Scott, can you just tell me who are the questioners, please?
So we have questions from Beth and from Sally, from Martin and David at the moment.
Okay, we'll take them in that order then. Thank you.
Thank you very much. We had a discussion about this very topic at the audit and performance as well on Monday. And I would personally like to commend the work that's ongoing. I think some of the transformational work is becoming obvious now, particularly on the frailty service. I think that's a big step change when we're actually looking at people's frailty rather than a number next to their name kind of a thing. The one thing I was wanted to just check up on and ask is about the hospital at home. It looks amazing. It's having really good results. And I know it's very early days and we're going to hear more about it after the first 6-month period. I think my question is, quite often we start these projects and they are really successful in our project areas. We then have real problems identifying how we step that up and move it out. I was just wondering if we get any plans about how we're going to do that within this programme. Thank you.
Thank you, Beth. I think that's a very valid point, and it's something that we've discussed as as part of the executive team, as well as how we scale that up. So the hospital at home service that we have at the moment is primarily based in Perth City and is very easy to manage within a Perth City locality, if that makes sense, because everything's so central. We're close to the hospital, we can connect with acute colleagues quite easily, and we have all the professional leads where we need them to support that. To scale that up, we have to give that a lot of thought, a lot of consideration. We really are looking to do a true integrated model. So would we have standalone teams is probably where we need to get to going forward, and whether we need to kind of step back and have a wee look once we do the evaluation to have that wider discussion to see how we would take it forward going forward, if that answers your question. I think Jackie wants to come in.
Jackie.
Well, thanks. I suppose it was really just the recommendation in the paper talks about evaluation, and I think it's really, really key that we don't proceed without a very thorough evaluation about what outcomes are we achieving through that, because it is a costly model to put in. Yeah, so the evaluation is key.
Thank you. The next one on the list was, who was it again? Scott after Beth?
It was me, Sally.
Oh, Sally, thank you.
Mine's just actually some comments because I'm sort of see quite a lot of this work actually happening, and I think there's two really important issues that probably weren't highlighted. No offence, Mandarin, that sounds terrible, doesn't it? But are really important that I've noticed a real change in the way that this work is progressing, which I think is really important. What we're noting now is we're thinking more about the whole system and patient journeys. So it would be lovely if people just hop from silo to silo to silo, from being well to not being well, and just kept, but they're not. And one of the real positives that I'm hearing, and I think we're discussing more, is about how we can support people across that journey, which is true integration. The other discussion that I'm really pleased that I hear is there is increased discussion about how we reach more people. There is probably only a small percentage of the older population at the moment that we're able to do, but there's been a real change towards that discussion about how we meet the needs of the housebound who might never come to the doctor, or we only see once every blue moon when their son can bring them. And those are two really positive changes that I've noticed, that I think it's just hard to get on a slideshow, really, isn't it? But I think that shows as well the progression over the last year work about how that whole system working is coming together, and about patient journeys as well.
Okay, thank you. I think the question is largely just there within it, isn't it? So it's all fairly clear, those comments. Thank you so much, Sally. And I really also welcome that sustained improvement as well. I've got David Illingworth and Sheila McCall.
Yeah, and can you tell me a little bit more about frailty at the front door, please?
Thank you. Yes, happy to. So frailty at the front door is really a service that we've designed that when you present into PRI, you will be assessed as whether you would fit into that category of frail elderly person, and you would be directed then into a certain area of PRI. So we have a frailty unit, and depending on your needs, they would assess you and they would look to manage your care within a sort of 72-hour window, if you like. And then they would make an assessment whether, well, are you fit to go home? And we would sort of coordinate the care around you to go home, or we would move you into a downstream ward where your care needs would be continued. But the essence of the frailty at the front door is you're managed by a team of professionals that are that have a medicine for the elderly approach, that understand frailty, understand the complexity and the comorbidities, and would do a full comprehensive what we would call a full comprehensive geriatric assessment, which basically means they just look at all your systems and all your support networks and your medication and everything, and do everything that is needs, you know, assess your need as per, you know, what you've been admitted with at the time. Does that help?
So front door is at the front door of PRI.
Chair, I was just going to say that acknowledging Councillor Stewart's comments and some earlier communication, it might be worth an opportunity at some point in time for IGB members to engage with the multidisciplinary team, just to understand that whole system approach. So I wonder if we can build that in on the back of this report, Amanda.
Okay, does that help you, David? I think that's a very useful offer, and I think we need to take that up. I've got I'm going to take Martin first. Sheila McCall has kindly agreed to stand aside for a moment. Martin.
Thanks, Chair. Two quick questions, and one that Sally identified something that I believe that we need to look at too is about loneliness for older people. I think it's a big impact on the services. But you've got that about dementia, care for dementia, and that process. Does that include the families of the dementia sufferers? Because if you don't, then they become the patients of the doctor. And how we do that. Your activity workshops in hospitals, are there any chance or are there any future plans to have them activity workshops in communities so that they're accessible easily?
Amanda?
Thank you. I might pass you to Chris, my colleague, to answer the dementia because he's leading the transformation programme.
Hello again. So I'm leading on the transformation programme around dementia care, and in answer to your question, Councillor Massey, absolutely. Carers are through the centre of what we're aiming to deliver on this. We're doing. Okay. Oh, sorry.
I don't think it's Councillor Massey.
Hello. Whoever Councillor Massey.
I think it's Martin.
Sorry, Martin, and apologies to Councillor Massey, whoever that is. Well, there you go. He's not even in the room. But yeah, so we're doing carers, we're doing the inpatient areas up at Murray Royal, we're doing our community mental health teams, and a wide variety of third sector organisations, particularly with Dave Henderson's support as well through the care homes and also Alzheimer's Scotland. And we're in the very early stages of this transformation programme, but obviously it's something that we need to get right over a long period of time.
Okay, that now takes me back to Sheila McCall. Thank you, Sheila. And then Ian.
Thank you, Chair. First of all, Martin sort of asked the question I was going to ask, because I think support for families, for patients with dementia, and even patients with mental health issues, including respite, is hugely important, because it creates a better living environment if that balance can be struck. But I have a comment to make, first of all, in terms of the early intervention and actions, the last point about establishing a food share network. And those who come to full council meetings and other committee meetings will know that I raise this point frequently, that food shares is not the same as a food bank. So we need to be because they're there for different purposes, and there's quite a few omitted from here that are community larders, etc. And they're open to everybody. You know, people can just walk in off the street. They don't need to be referred. Some of them are about, reducing waste. And so there's quite a few organisations that aren't included here. So I just think we need to be careful about the language that we use in that particular piece. And these are run by community organisations. In terms of community organisations, I'm just wondering what engagement we have with them, because they often will establish, particularly in areas of high density or deprivation, and people don't really like to leave where they live, establishing activities and various other things, and there's no mention here of how we engage with these types of community groups. I probably should declare that I'm a trustee of Lethem for All, and we do quite a lot of work in terms of engaging older people, getting people out to walk. It's almost the prevention as opposed to the early intervention piece. So I'm just wondering, how we can engage with those organisations as well. You don't need to answer that. It's just a question I'm throwing out there. And I know, Kenny, we've talked before in the Adult Support Protection Committee about how we get input from those organisations, because people will sometimes come to those sorts of places before they even go to their GP. So I think, and there's possible signposting from there might be easier for people than signposting from somewhere else. So it's just an observation, really. And my final point is just, I'm assuming this is aligned with the primary care service development work that's going on. I'm just assuming that's all aligned. But it's good work and it's fantastic. Thank you. And it is, I discovered from Councillor Ian Massey, who's our older person's champion, that anyone over 50 is classified as an older person, much to my surprise. I was wondering when I might reach that status. Pardon?
Yes, yes, I would go down that road, Sheila, if I were you.
I think it's something of interest to all of us, and it might be worthwhile, having Councillor Massey as perhaps somebody that you consult on this project going forward, because and he then has reach into the council like housing and other services.
Thank you. Thank you, Sheila. Amanda, do you want to pick up on the community engagement bit and the link to primary care services?
Thank you, Chair. Yeah, I think just to say that we do link in with our what we call our healthy community collaborative workers and our community engagement workers to try and make those connections with community organisations. But given where we've been, I think coming out of COVID, I think we need to now really refocus on that, and really, I think this is a key area of work we need to go back and look at in terms of our early intervention and prevention. Zoe, I don't know if you want to, is there anything else you want to add in terms of that approach?
Yeah, we have an early intervention and prevention work stream with very broad representation from across community partners and CPP partners as well. So, and we're in the very, very early stages of doing some engagement work with a couple of the community trusts in the Highland area. So, looking at the opportunities to work in an alliance model with multiple trusts across the whole of Perth and Kinross. So yeah, an area of development we're really keen to explore in more depth.
Thank you very much indeed. Ian, a final point on question on this, and then we'll move to a comfort break. Thank you.
Thanks very much. It was just a point in respect to the discussion about the cost of scaling up or being unable to scale up. And this is one of the areas where I think it would be so difficult for staff, having put the work in to invest personally and professionally, and we get to the point where this is a service that can work and it doesn't because there isn't resources. And I was wondering if within the planning process, do we have an initiative like Save to Invest, where we look at, for example, the cost of unable to discharge someone, and they may well remain every day for weeks and weeks on end in a bed within a hospital, and the cost of that, but actually saving that by investing in the proposals you've put, and it's an understanding that that saving gets transformed over, because as the service grows, the loss of that resource is removed, but also it means for the families concerned and the staff in the community that it does work, it can work and will work.
Okay, I mean, I think it's a very well made point. Amanda, do you want to pick up on that? Because I think that is one of the issues that arise constantly in these matters. Thank you, Amanda.
Thank you, Chair. I'm going to direct it to Donna, who's going to pick up some of the finance stuff, and then Jackie wants to come in. Thank you.
Yes, I thought they
Thanks,
might.
Amanda. Thank you, and I think it's a very well made point, and I would like to say that I'm quite proud of this IJB, that for the past, I would certainly say, 5 or 6 years, our financial plans have been heavily based on an invest to disinvest strategy, and we've got a number of examples of that, and it certainly, while we have the resources to do so, one-off funding will be used in the best way we can, and with a strategic vision to not just spend money and it go into a black hole, but to actually allow us to use it as a change fund. So, yeah.
Thank you. Jackie Pepper?
Yeah, I was just going to add, in answer to Ian's excellent point, that we've taken the opportunity to deliver some of this presentation and other material to Perth and Kinross Council's executive leadership team, its transformation board, and on to NHS Tayside on Monday at Business Critical Gold, because it's really important that we engage all our partners in this and we see that whole system. But beyond that, we also need to engage, and I know we've had discussions before with our community planning partners and the strategic leadership and decision making around this, because the resources that are at the disposal of the IJB are not the only resources, as in terms of people, community assets, etc., that we need to be addressing our particular population challenges.
Thank you very much indeed, and I'd love to talk a bit more about these population challenges, because we're really only dealing with people already within the system, not those who may enter the system in 5, 10, 20 years. So, but that's a wider discussion. Thank you so much indeed, and I think greatly welcome this sustained improvement. I think it's a great document. I really feel that we're doing a lot of good work here. Let's break for 10 minutes or so, and I shall see you then. Okay, thank you. Okay, then are we ready to come together again? Scott, are we ready? Thanks, Scott.
Chair, I think we're all back and ready to get going.
Thank you very much indeed. In the interest of comfort breaks, I forgot to actually ask for approval of the recommendations within the Progress Against Older People Strategic Delivery Plan. Do we approve this? Assuming that's correct. Okay, that seems fine. Thank you. That now takes us on to the 7.4, the annual update on substance use services. And I've got Kenny and Charlie next to this.
Thank you, Chair. And as you say, I'm joined online by Charlie Cramner, the ADP coordinator. And also in the room, we've got Chris Lamont, who is the Senior Service Manager for Mental Health and Substance Use. The purpose of this report is to update the IJB on progress in the redesign of substance use services, including embedding and implementing the medication-assisted treatment standards and work to progress the outcomes of the current Alcohol and Drug Partnership Strategic Delivery Plan, which runs from 2020 to 2023. Nationally, drug deaths declined by a fifth in 2022 from the figures in 2021. However, in Perth and Kinross, there was an increase of 1 person. The implementation of the MAT standards continues. In April 2023, Perth and Kinross was awarded in a national benchmarking exercise, amber regarding the implementations of standards 1 and 2, and green for standards 3 to 5. Nationally, there was a 2% increase in alcohol-specific deaths in 2022 from 2021. And in Perth and Kinross, there was an increase of 2 people. As with drugs, people from deprived areas are at greater risk of dying than people in affluent areas, although the difference for alcohol-specific deaths is smaller. The number of people seeking support for drug issues fell in 2022-2023, as did the number seeking support for alcohol issues. However, the number of people seeking support with both alcohol and drug issues increased. The ADP Strategic Delivery Plan has been refreshed and significant progress has been made regarding achieving the 6 outcomes, including the Alcohol and Drug Ambassador Project with young people in Crieff, improving access to naloxone, improving harm reduction, the introduction of same-day prescribing, reducing waiting times for access to services, access to Buvidal, improved access to residential rehab, the implementation of a community detox service for alcohol, increased counselling capacity for people with alcohol issues, the ongoing development of recovery cafes across Perth and Kinross, and the ongoing development of the non-fatal overdose pathway. A new 3-year ADP Strategic Development Plan will be developed to continue to embed the actions in the current plan and identify new actions to address emerging issues, including changing drug trends. It is recommended that the IJB notes the progress in the redesign of substance use services, notes the progress in embedding and implementing the MAT standards, notes progress with the ADP Strategic Delivery Plan, retrospectively approves the ADP Annual Reporting Survey for 2023, which is attached in Appendix 1 of the report, and requests an update in 12 months' time. Happy to take questions.
Thank you very much. Questions for Kenny and Charlie?
Can I ask a question, please?
Yes, please, Ian. Thank you. Proceed, and then I'll take Sally.
Yeah. Thanks for the report. As always, it's always a difficult issue in the community. And declared interest that tomorrow will be the anniversary of my son's death. For the first time, he will be dead longer than he lived, and that's a point. But there is a reason, is that on the issues of, again, resources, what's the position in Scotland about proceeds of crime legislation and whether some of that can be allocated to activities and work that you wanted to do, whether it's in Perth or in the rural communities. Thank you.
Thank you, Ian.
I am not sure if there's any specific allocation from proceeds of crime monies. I'm looking at Charlie online, who has got more experience in the criminal justice sector than myself. I mean, Charlie, have you any idea? If not, we can certainly find out and get back to you.
There's nothing specific that I'm aware of that comes to ADPs or enhances the substance use budget directly.
Okay, thank you. I think you've got your answer there, Ian. And if there is anything that they can glean that's helpful to what I suggest you were asking the question for, then we'll get back to you. Sally and then Martin, and then a question from Sandra.
Mine was just a quick query about data, and you may not have the full answer. I always find, particularly with the drug and alcohol data, really hard to look at, because is it going down because people don't feel they can access services, or is it going down because people don't need those services? And I often find it quite difficult to be able to evaluate how well things are going on that sort of data. The other question I had was, do we have any data about outcomes for people? Are we noticing that implementing these things are resulting in more people gaining, having alcohol detoxes and not going back to alcohol? Because that's obviously, it's important about the outcomes for the people involved.
Yeah, actually monitoring or identifying the impact of services is an ongoing issue. And I think it's fair to say, in terms of determining the impact or identifying the impact of services in terms of personal outcomes, is still very much a work in progress. That said, there's been a lot of development in recent years. We have really good support from our public health colleagues, and we do have a suite of indicators that it gives us a reasonable picture of how things are progressing in Perth and Kinross. And we do now have a national database called DAISY, which is up and running, and that provides data collection in a consistent manner, so it's, at least we're able to benchmark with other areas in Perth and Kinross. I don't know if Charlie wants to come in. With our MAT standards, we also are working very closely to get service user feedback. So we're getting that qualitative information. I mean, we've talked about care opinion here before, but in terms of the MAT standard, we actually have dedicated resource to go out and do face-to-face interviews with folks. So we are gathering that information from certainly a sample of service users. Charlie, have you got anything else you want to add?
Thanks, Kenny. It's two really challenging questions to try and answer, because you're right. If the number of people accessing services is going up, is that because there are more people needing services, or are we doing a better job perhaps in publicising the services that are available? If the numbers go down, again, there are similar arguments. I think we've definitely, as Kenny said, there's a lot of work been going on over the past 12 months, certainly with the introduction of MAT standards and other initiatives, to make sure that people are aware of the services that are available in Perth and Kinross and find it easier to access them. So I would like to think that with that in mind, if the number of people actually accessing the services are decreasing, then it does perhaps suggest there is fewer people who are looking to access services at that point in time. On the issue of outcomes, again, it's very difficult. It's something that is quite challenging to measure, but as Kenny said, one way that we're trying to do that now is through our qualitative interviews to assess the impact of the MAT standards. Another thing that we're doing is we've recently set up our living experience group, and that way we're able to speak directly to a number of people who are using services at the moment to get their direct feedback, with a view that we can use that feedback to improve the services that we're operating. So sometimes I think this is maybe a case where the numbers themselves perhaps don't tell the whole story, but getting that rich qualitative information can help us to determine just what's working and what other things need to be enhanced.
Thank you. That takes us on to Martin.
Gordon, thanks for the report, and I have a few comments and questions on this report. And firstly, on the outcomes, they're all fair enough and they're all the usual outcomes, okay, but how do you reduce a risk for somebody who's already taking harmful drugs? If they're taking harmful drugs, then that's a problem. Ken, how do you actually start to change what we're reporting? There's so much money that could be invested in drug alcohol works if we had some correlation of the facts. What is the impact on the health service for people to take alcohol and drugs? What is the cost to the health service? What is the cost to the judiciary, to prisons, to police, to judges? What is the cost on housing? What is the cost on social work? See if we got all the costs that's associated with drug and alcohol use and addiction, because there seems to be a separation here for use and addiction. Ken? But because you didn't tell somebody who's addicted how to do something safely. And I always declare, I've been 32 years in Alcoholics Anonymous, so I've some experience in what I'm talking about, like. But I think we actually look totally at the wrong things. We look totally at the wrong. How are we going? How many rehabs are in Tayside? How many people are sent to rehabs in Perth and Kinross? Ken, what is the criteria? How quickly can they access rehabs? How quickly can they access intervention with people who have experience, lived the experience? Ken, we've got a lot of well-intentioned people who will tell you to tick boxes, and that just didn't work. Didn't work. Sorry that I'm a wee bit negative on this, but it does my nutting. Ken, quite honestly.
Well, I think we got. I think we got that message.
We keep looking at the wrong stuff.
Yeah.
We keep looking at the wrong way of recording the impact on society and the impact on the users. Try to get the information that elicits that information. Then you might have a chance of improving recoveries.
Martin, I think there's quite a lot in that, and some of which I'm just trying to sort out what the question actually was. Some of it is about questioning the basis of what we're reporting on. Kenny, do you want to start off on that, and we'll bring in Charlie? I'm not sure about the costings bit, because I'm not sure that's what our job is, but there is a cost to us. Yeah. Okay. Right. Thank you. Kenny, do you want to start off?
Yeah, I mean, certainly in terms of the cost to society, it's absolutely massive when you total it all up, and prevention is obviously better than cure. And that's, with the ADP can only do so much, but we have to look at our sort of wider society and wider community planning partners to, look at trying to reduce poverty, trying to support people who have experienced trauma, trying to ensure people have adequate housing, trying to ensure people are in employment, trying to ensure people with mental health issues get quick access to support. And certainly in terms of accessing substance use services, we have reduced our waiting time significantly in terms of people requesting support. And obviously those all requests are prioritised in terms of need. But I think that, one of the keys is to have a suite of treatments and options available. It's certainly not one size fits all. And for some people, kind of extremely chaotic lifestyles, you have to focus on harm reduction. You have to look at, for example, working with them to reduce the amount that they're drinking or the amount of drugs that they're using, or if they are, for example, injecting drugs, at least making sure they've got clean injecting equipment. For other people, you can maybe move straight to a sort of abstinence phase and maybe go straight to trying to get people to abstain altogether. But, sometimes it's a combination of those approaches. Sometimes one is better for one person, one might be better for another person. And like I say, the key is to try and work with the individual and make sure they're getting the appropriate support that will work best for them. And, that's the key to having a range of services and supports there across the statutory and third services sectors, making sure those services are all joined up in a coordinated pipeline. So no matter where people are presenting, and that's why we have our multi-agency assessment clinic. So people's information comes into that clinic, and you have all the statutory and third sector organisations there, so people can get directed to the best place for them to get the support that's going to help them the best. I don't know if Charlie wants to come in with anything else.
I think you've covered that pretty comprehensively, Kenny. I suppose there's just a couple of small points. The Scottish Government do produce or have produced statistics on the cost of substance use in various areas, as they produce statistics on the cost of crime and things like that. Those statistics at the moment are quite out of date. So that's not something that we can rely on at this point in time, and I would hope they would be updated fairly soon. But it's certainly clear that there is a massive societal cost across all different services and systems when it comes to people using different substances harmfully, and that's certainly clear. Even when the stats are updated, I'm sure that won't change. You emphasised as well, Kenny, that all the different services that are involved in trying to support someone who's looking for help. In addition to the things you mentioned, we also have our recovery cafes and our recovery activities in our different communities throughout Perth and Kinross, and they are often just as important as the statutory services and the third sector services that we have as well. As an ADP, we're trying to develop the system. We're trying to develop a network of support that we can wrap around people to help them with whatever it is they're looking for, and that extends beyond substance use as well. Obviously, people may as well have issues with housing, may have various different issues. So we're trying to make sure that we join up with lots of different services across the piece to provide people with the help and support that they need, which may change over time. That even when someone comes into services, they may at some point later down the line have different needs and wants, and we have to make sure that we can continue to respond as best that we can, and that's certainly what we're trying to do.
Thank you. I'm now going to take Sandra Auld and Sheila McCall and Colin Stewart in that order, and then Jackie Pepper's going to have some comments to make. Thank you.
Thank you very much, Chair. So thank you for the report. So that it was really helpful to see that. Following on from some of the comments Kenny has made, he made reference to a suite of options and treatments, and I wondered if there were any plans within Tayside moving on from the progress that has been made very recently in Glasgow around legal consumption rooms, and the statements that have been made, or the indications that have been made, that prosecutions would not ensue from these, and also the UK government making it clear that they wouldn't try and intervene and stop the plans for these. So bearing in mind that the figures for Tayside show an increase in deaths from the previous year, I wonder if this is something that is being looked at.
Thank you, Kenny.
I mean, certainly in Perth and Kinross, we have no plans at the moment to look at drug consumption rooms. There is good evidence from around the world that drug consumption rooms, they do work. They certainly reduce harm, and they can reduce the immediate risk to the person. But one of the big advantages is they can then give an opportunity for people to work with that person and help them access other services. They do not work in isolation, they work as part of a wider system. They tend to have the biggest impact where you've got a high concentration of people, of intravenous drug users. And again, in particular, if people are homeless or rough sleeping, which we don't really have that concentration in Perth and Kinross. And certainly, it's been in the press, fairly well publicised. Glasgow are looking at piloting this. Edinburgh are also considering it as well. I'm not aware of colleagues in Dundee. We're actually in a call with them this morning, and they didn't mention anything there. I'm sure they are considering it, but they haven't said anything to us about actually trialling that. So obviously, if a pilot is up and running in Glasgow, we will watch that closely to see the impact of it and just see if there is any learning that we could use in Perth and Kinross.
Thank you. Councillor McCall.
Thank you, Chair, and thanks, Charlie, for the report. My question, Charlie, is on section 3.6.4, the work with the Community Justice Partnership, and specifically about the test of change to explore how best to support people with substance use issues who are arrested and held in police custody. Now, for a while, people were being transported to Dundee and held in custody there. I'm not sure how prevalent that still is, but I'm just wondering if Dundee police are involved in this test of change. Thank you.
Yes, they are, I think, is the short answer to that. So the arrest referral pilot test of change has been running for a while now. Dundee were the first to start that, and Perth and Kinross and Angus came on board a little later. We've been able to try out a few different models to see how best we can try and provide a service to people in police custody. However, more recently, Barrack Street's reopened to deal with some levels of police business. So now not everybody from Perth and Kinross is going through to Dundee Custody Suite for processing. As a result of that, the arrest referral model that we're using, we've decided to change that to try and make sure that people in Perth and Kinross are provided with a service across the piece. So we've actually ended up now with 3 slightly different arrest referral models across Dundee, Perth and Kinross and Angus. And that model's still evolving. We were originally working with a third sector organisation to provide that arrest referral support. However, because of the geography of people going to Dundee for processing but living in Perth and Kinross, we found that model sometimes didn't provide the most optimal solutions. So we now have a different model that we're trialling. We're still working with the police officers in the custody suite to look to see how they can get information to Perth and Kinross for people that are in their care, but we're also looking at how we can perhaps focus on other opportunities to interact with people, particularly Perth Sheriff Court as one example. So it's a test of change that's constantly evolving. The learning from it is particularly valuable, and I think we'll continue to adapt and enhance the model as we move through the remainder of the test of change.
Thank you. Sheila, you want to have another follow-up question?
Thank you, and thanks, Charlie. I suppose just the initial feedback when that started was that, people who had also substance abuse issues, but also maybe had mental health issues, that the mental health issues were exacerbated by the transportation to Dundee, particularly if they're held in custody there. So I'm really encouraged that it's evolving. The other thing I noticed that you mentioned CAF as supporting people coming out of short-term sentences, but you haven't really mentioned the Homes First team in Perth and Kinross Council, who quite often offer a wraparound service to help people, not only get housing, but to maintain that housing. So I think that's quite an important aspect as well, because they bring in services too through the council housing team. Thank you.
If I can just follow up on that at that point, and Councillor McCall. Yes, it's a point well made. The voluntary through care project, the voluntary through care test of change again has evolved, and the next stage of that is to involve our colleagues from Floating Housing Support as well, to be one of the services that we can call on. So that's something that again is continuing to develop as we continue to learn more about what's actually required. We're extending that model to include people on remand, which of course is quite a large population and quite a challenging problem to try and deal with. But hopefully by expanding the test of change, then we can provide better services to try and help that population as well.
Thank you very much indeed. Councillor Stewart.
Thanks. I've got questions on 2 very different areas. So I'll ask the first one and then come back in later on the second. My first question is about is on section 3.4. So this is about the recovery services. Can I just say that the table in figure 5 showing that we're now getting up to a 94% percentage of people waiting 3 weeks or less. That's really great and really to be commended. That's a huge shift in the last 2 quarters and really to be commended. What I was wondering was, though, firstly, what would that look like if we used less than 2 weeks or less than 1 week? And then secondly, in 3.4.8, we're talking about 17 requests for accessing residential rehab being approved. And I just wonder, kind of following up on Dr. Peterson's question, what the results there are in terms of, actually making a permanent difference in terms of rehabilitating somebody without relapse.
Okay, Kenny?
Yeah, in terms of the waiting times, my understanding is that the vast majority of people are seen before the 3 weeks. Again, we can give you a breakdown of figures. Obviously, we use the 3 weeks because that's the national heat standard, but yeah, we certainly do have the breakdown there, and most people are seen well before that. In terms of your next question, in terms of longer term outcomes for people in residential care, it varies. It varies. I mean, the real challenge is, people go into residential rehab, they can make significant progress there. The big challenge, obviously, is when people come back to their own communities. And what we've done, we've obviously reviewed the pathway for people accessing the care, but we've also reviewed the support that people get when they come out. So everybody, when before they come out, they get a key worker allocated from our IDAC team, and they work with them when they come back home to try and ensure that that recovery is maintained. I don't know if Charlie wants to come in here. It's probably a mixed picture in terms of the longer term outcomes for people. But again, bearing in mind, most of those 17 have only gone in fairly recently, so it's still fairly early days for people coming back home. Charlie, do you want to come in?
Just to agree with your comment there, Kenny, it is quite early days for some people, and also we are aware that often it takes more than one program in residential rehab for someone to actually reach the point that they would like to get to. Sometimes it involves maybe 3 or 4 different visits to residential rehab for 12 or 6 week blocks before someone can really make the change that they want to. So it is relatively still early days for our residential rehab pathway and our pre and post work. As Kenny said, that's certainly a crucial aspect of it as well. We need to make sure that we have the best available pre-work and post-work for people going in and coming out, and that's something that we're focusing on at the moment. And we're working at the moment with Health Improvement Scotland, as a number of other areas are, to enhance both our residential rehab pathway and also to look at that pre and post-work and try and make sure that we're providing the best service that we can.
Thanks, and maybe just a quick follow-up then. You were talking, Mr. Ogilvie, about the assignment of key workers when people come out, but the risk when they go back to their community. As part of the sort of wider community planning partnership working, are people supported to move elsewhere when they come out of rehab? So, if their particular geography previously had been part of the issue, do we get our housing colleagues involved in order to try and find better accommodation, for example?
Yeah, yes, I mean, if people express a desire to change their geographical location, we will work closely with the housing colleagues to try and facilitate that. Yeah, yep.
Okay, thank you very much indeed, Colin. So that takes me now to Councillor Frampton, and then Bernie. Thank you. Councillor Frampton, are you there? Okay, I'll give her a moment, and I'll take Bernie first then.
Thank you. Mine is just a question really in relation to the link between somebody who is in hospital, going to be discharged, known to have a problem. And I'm just wondering if there's a link between that person being discharged from hospital and them going home, knowing that they're, they could be in a difficult situation. Again, is there any link between that, or are they just discharged from hospital and then they're told, well, you'll need to make contact with the service? Now, the reason I asked the question is I can give you an example at which I was made aware of by a carer, and it's only a few weeks ago. And obviously there was concern about a family member who had been in hospital. I'm not sure what the reason was for being in hospital, but they were being discharged home. And the carer was really concerned because the family member who was being discharged home, they were fearful that they were just going to again perhaps end up in a challenging situation, but they were told really that you need to contact your GP. And I'm just wondering, is that, so if you have somebody in hospital, they have a problem, obviously family have got a concern, are they discharged home saying, well, make contact with that service, or is there a link between the hospital to support them before they're discharged? Thank you.
I mean, again, people shouldn't be discharged from hospital back home to a home situation where there's an unacceptable level of risk. In terms of any services and supports that are required for discharge, I mean, again, the person should be assessed in hospital and those arrangements put in place before they discharge home. That said, being in hospital isn't risk-free itself. I mean, in the hospital, you have to weigh up the potential risks of hospital-acquired infections, people reducing their functional ability because they're bedbound, etc. So, it's not a black and white picture. Plus, there is the demand on the whole hospital system, and there may be somebody who's more acutely unwell who requires that bed. So it can be a mixture. I mean, if people are mentally alert and are saying they're willing to go home and able to contact services themselves, then they can be given that correct information. But again, if there's any dubiety, the contact should be getting made from hospital, and obviously the service and support is prioritised for the person returning home. And again, if you've got a specific example, I'm happy for you to give me the details out with.
Okay, thank you very much. I think Councillor Frampton's back in again. Councillor Frampton, do you want to ask your question?
Hello.
Can I just,
Carry on.
sorry, it was just to go back to Kenny saying thank you for the situation. It wasn't that the person didn't want to go home. They did. I think the family member was concerned about they were going to go back home and what was going to happen 24, 48 hours afterwards. And it was their concern that it was just contact your GP. And I mean, I'm not sure what happened in the end, but I was just wondering if there is a link between when somebody is in hospital for something and they are known to have a problem or known to the service, would there be some sort of support? But thank you.
Kenny?
Well, I don't think I've got anything further to say on that one. Thanks, Chair.
Okay, thank you. Okay, Councillor Frampton.
Hello. I had a comment plus a question to add at the end of this. And it was on the reduction of people who take harmful drugs. I agree that prevention is key to helping the addicts and alcoholics. In Tayside, we have many areas of treatment available. However, even the approach of the methadone programme is really for drug addicts. What they're doing is replacing one drug for a controlled drug until they get their next preferred drug fix. So much of this doesn't work, and lives are lost because of this. It is a hard task to eliminate drugs in their lives. Some will reach out for help and many choose not to. For instance, I mean, I know most of this because I started a programme called Still Waters that reached out to help drug addicts and alcoholics on the street. That has now been taken over by the Nazarene Church and dealt with on a weekly basis. I also carry my naloxone on me at all times. And last week I came across a lady who had clearly had far too much or whatever the drugs were. I know that she's also on the methadone, and the police had been and saw her lying on the street and had called an ambulance. When I approached her, I was standing beside a lady who worked in prison in the NHS there. When I asked her if the lady was okay, she said, I don't know. So I bent down to try and get a response out of this lady. Eventually, I'd managed to get a response out of her, and I told her that I had naloxone on me and offered to give her the injection for it. 3 times I offered the injection, and 3 times the lady refused. So I had to just leave, knowing just as I left, that was the ambulance arrived, you know, to respond to her. So I want to know, how much does this impact ambulance services in the NHS, where people such as me are, you know, willing and trained in carrying this naloxone, and yet, you know, they refuse to take it, and then ambulances are having to be called.
Thank you. Are you a registered nurse, Councillor Frampton?
No, I'm not a registered nurse, but I was trained to give the naloxone injections.
Thank you for that clarification. Kenny.
I'm afraid I don't have any figures for the impact on the ambulance service, but you know, it is considerable responding to people under the influence of drink and/or drugs. Certainly, in terms of your comments regarding methadone, I'll go back to what I said before. You know, for some people, harm reduction works. For some people, it's better trying to move straight to abstinence. And, you know, methadone has been proven to be beneficial for some people, at least, you know, addressing initial chaotic lifestyles and then working with people to reduce that down. Where it's more of an issue if people are on methadone for long periods of time without any other intervention. And obviously that's what we need to make sure doesn't happen. So if people are on a methadone programme, they are getting that range of other supports there to try and reduce that and wean them off it altogether.
Okay, thank you very much for that question. Colin, did you want to come back in again with a second question before I go to David?
Thank you. So my other question is a completely different topic. In 4.3, sorry, there's reference to this being the reporting against the 2020 to 2023 plan, ADP strategic delivery plan. I just wondered when, under 4.3 says that we need a new 3-year plan to be developed. And I just wondered what the timeline was for bringing forward a 24 to 27 plan, and whether that needed to be in the recommendations as well.
I'll maybe bring Charlie in if that's okay in terms of the timescales for the next plan. I'm hoping he's not frozen.
No, it's something that we're in the process of developing. We've been holding off a little bit because we're waiting on some clarification from some of the MAT standards work from Scottish Government. We're still waiting on clarification as to the detail around MAT 6 to 10. But we're in the process of developing the plan at the moment, and once we get that clarification from Scottish Government, which I believe will be next month, then we can firm up the timetable for launching the new strategic development plan, but it will be early within the new year.
Okay, so I take it from that we're not going to ask for a further recommendation to be put into this paper, which I think is what Colin had asked. That takes me to David Illingworth and then Jackie Pepper and either Sally or Hamish Dougal.
It was just a quick comment. I think one of the things that I think we always have to remember when we're discussing things around drug and alcohol is about how complex the issues are, and also about how difficult the lives can often be of people who are troubled by drug and alcohol, whether that's from the past, from the future, and also what these people have to deal with on a day-to-day basis. And I think that's one of the things that we remember. I think we always have to remember. I think it would be lovely if we could make people do what we wanted them to do, and that would make my job a whole lot easier. But I think one of the things we always have to remember is that people do have autonomous choice, and that may not be the decision that we'd make, but a lot of the positivity that I hear coming from particularly from Charlie and from Kenny is about person-centred approaches, about the fact they are looking beyond things such as trauma experience and things like that. And I think we can all be mindful that this is a really difficult and complicated area with a lot of additional challenges that maybe some areas don't have quite as much of.
Okay, Jackie, do you want to come in? I don't know if David's back.
Okay, oh, no, I'm just grateful for Sally coming in there, because I felt we needed to have a clinical perspective in terms of some of the discussion. But the report, as well as outlining the whole range of work that's going on here, I think does give a sense of the impact that the whole range of that work is having on people, and a sense of the stickability with people through some of the difficulties, challenges and difficult decisions and chaotic circumstances they may find themselves in. And that I think we need to recognise that in this report. It's about having a whole range of options for people, and that there's assurance in this report that the range of services that we're providing are sticking with people in the most difficult of circumstances.
Thanks very much, Jackie. I'm just thinking about when we're talking about older people's services, and just about maybe go into some of that. We're thinking a bit more with the visits around multidisciplinary teams and so on and so forth. Is that something that board members would welcome, do you think, as part of out with the paperwork here, to actually engage with them, to, because some of the things you're talking about there may not be easily reflected in a paper?
I think that's absolutely right, but I think there's a whole host of other material that could be made available, as well as visiting some of our services and speaking to staff and people who use those services. For example, I saw photographs of some work that some people had been carrying out in one of the recovery cafes. Replica guitars produced, for example, through some woodwork activity. Seeing some of the demonstration of the creativity, the support, and what people can achieve when they're supported to do that, I think would be very beneficial for the IJB.
I agree, and I think it's getting some insight to what some of these other areas do, and I know that other people want to talk to the board at a future date. Maybe we need to ponder on that and see how we can best facilitate some of that, Jackie, just to see some of these other bits of work from service users themselves. Okay, David, I don't see, are you still pushing for a question yet?
Yeah, just trying to understand what the benefits are of Buvidal. I think that's right. Yeah, thank you.
Basically, Buvidal is a long-acting injection, and it can benefit a range of people. It can benefit people with like really chaotic lifestyles that struggle to go into regular appointments to take supervised methadone. But it can also benefit people, for example, who are functioning at a better level, maybe have a job, for example, and because they're working, they don't have time to go to the chemist, or or taking the methadone interferes with their jobs. So again, if they get their injection, that means they can then get their injection once a week, and they can go on with their lives apart from that. So yeah, like I say, it doesn't suit everybody, but there are a large number of people that do benefit from it, and it's better than other options.
Okay, thank you. I'm going to bring this to a close on this particular paper, and I'm going to go to the recommendations, and there are 1, 2, 3, 4 recommendations. Does the board accept recommendations to the IJB? Yes, is that a yes? I take it as I can't see people in the room. Thank you. That then takes us to 7.5 strategic planning group update. And Zoe, I believe you're doing this and you're doing this with Ian, is that correct?
Yes, that's correct, yes.
Thank you.
Okay. So the 16th of August, we held our strategic planning group in a slightly different format and used that as part of our strategic commissioning plan consultation activity with a focus session with our workforce. And Ian's going to give us some feedback on that after a brief overview of the consultation process overall from myself. So we undertook this consultation process over the months of July, August and September. We ensured that all materials were made accessible. We ran 18 individual in-person events over the 3 localities in the afternoons and evenings. We produced promotional material and sent that to 944 individual people and community groups across Perth and Kinross. We used online and paper questionnaires with over 378 posters, paper posters being distributed as well as Facebook, etc. activity. We produced an easy read guide to the consultation. A film was produced and shared widely on social media. I believe in the region of 85,000 followers that use those social media sites. Additional targeted sessions were arranged to ensure a wide range of groups were represented in the feedback, and also arranged because during the consultations sessions, which I attended most of, we weren't getting as much input from some services in and around mental health, for example. So we ran additional specific targeted sessions for people who use mental health services, learning disability services. We ran some targeted sessions with minority community groups, the Gypsy traveller population. We did some consultation with the reference group and older people community services. And then, as I say, the targeted workforce session that we held on the 16th of August. We've had 367 individual questionnaires handed back in. We've had 200 attendees at the locality sessions, 98 attendees or contributors to the targeted sessions, and 51 staff came to our SPG session specifically. So around 716 people have contributed to the consultation to date. Ian's going to present some high-level findings from the workforce event that he attended, and this includes staff's wishes, worries, and their opinions and views on the delivery of social care, primary care, unscheduled care, and what matters to them. And next week we have a joint session planned for the IGB and Strategic Planning Group, where we'll present the entirety of our findings, including the Joint Strategic Needs Assessment findings, but all of the feedback from all of the consultation activity. Hand over to Ian.
Ian.
Thank you. This is worse than going for an interview. So we'll see how it goes. Thanks, Zoe. Can I say that before I give the outline, 2 things. One, my report's neutral in the sense there's none of my views expressed in this. This is entirely 100% the views of staff members through their experiences and professional qualifications. Although there are some obviously I would really support, others maybe, no. But I just want to make sure this is their views. And secondly, I'd like to say that what impressed me was the quality of the staff who came to these events, their technical ingenuity and knowledge, but their willingness and preparedness to come and have dialogue about how to improve even the most difficult of situations. They had a view to do so, and that's something that this going forward we need to capture and continue with, because there's clearly out there in the workplace not just knowledge but commitment, empathy, and a wanting to work and be part of what we're trying to do and reform. And so that was, from my point of view, I remember that this body was excellent and should build on it. Now, in terms of workforce worries, Are we circulating this? This isn't a private special document, is it? No, it's circulating. Yeah, so I won't go into all the graphics on it, but this sets out their kind of main worries and also about communications and their way that they'd like to see communications improved internally, either between different parts of the workforce, health and social care, or with the organisations that are engaged in these kind of exercises. They want to make sure that communication could be improved, and some had comments about how to do that. They wanted also to ensure that there was some continuing dialogue out of this process to not make it a one-off, heard your views, and a few months later, this is what we're doing. They want to have a continuing involvement. And again, I thought that was a really good feature of the discussions that took place. Primary care, from primary care, we had a significant group of staff who were interested, first of all, I think, in better ways of integrating with their role with the health care services and other and within the community, about how they could operate more effectively in the community with having responsibility to looking at casework and cases, a bit like at they're currently doing in one or two of the sites. They'd like the staff would like that to be developed, and in terms of the integration, they want to see that in reality, having the capacity to go a bit more faster, I think, than what we do now about being in partnerships. There were also a concern about the lack of information and understanding in the wider community about services and the roles that they play in the services, and they would like to see us having how we could improve this, because they say it's a significant barrier to early intervention, this area. And
Can I just
well, you want to learn some English? Was that about you and me?
It was Bixby,
I knew this wouldn't go well.
At least it's hearing your voice nice and clear.
All right, thank you very much. And they would like to see, as part of future planning, that they get an opportunity in doing that, working with a client base and feeding back what the clients are saying about potential improvements, either that they would like to see or we were in consultation looking to provide. And so, again, I thought that was quite important, their willingness to take some leadership role in engaging their clients in a way which is somewhat difficult for many clients, isn't it, given their illness or where they're located. The fact that they were prepared to want to do that was encouraging again. There were 6 key themes, I think, coming out of this, so in terms of the overall discussions and the contributions. One's the increased integration of services to support the partnership working, which would lead, as they believe, to significant improved service delivery. They want to ensure that we have the right services in the right place and people know how to access them. And that was a constant theme coming out, both between the primary care staff and the NHS staff. They wanted us to look to make sure we consider a range of approaches to improve time efficiency for social care workers moving between appointments. And that was not just a big issue for them. Also, I think it was a drag on being able to successfully recruit people to particular locations outside of Perth City. that they see the need to improve the way that they are able to work with clients in rural areas. They wanted to promote the value of volunteering within communities. And again, there's been much coming back, which you'll find out later, about the community meetings that were held. That gave a huge amount of opportunity there about looking at how to improve volunteering and the value of it. The value continuous feedback, which I think I covered, and they wanted an environment, a work environment and an overall social environment where people's contribution is valued. And that is a critical, and it's come out in other surveys, I think, over what's gone from COVID, etc. The feeling of isolation and not being valued. And that came out that they really would like people to understand what they're attempting to do, and that they would value feedback and encouragement. That's it. Thank you.
Thank you very much. Thank you very much indeed, Ian. So you might be able to sit aside and put your feet up if Ian's going to do the presentations like that again. Eh? I was going to say is that many of the things you talked about, Ian, are very reminiscent of some of the discussion at the Employee Partnership Conference yesterday in Tayside that were picked up at the IJB Staff Forum table, as it were. Questions for Ian and Zoe?
The trouble here, the medical. Oh, sorry.
I was just wondering who was involved with this, because you've talked about primary care, and I'm just wondering how many GPs and GP practice services were involved in these discussions, because I quite appreciate they're independent practitioners, but we do practice under the NHS Tayside and the Health and Social Care Partnership, and I was just wondering how many went, because they have a substantial involvement in providing care within the area.
I don't know specifically, Sally. I'm not aware of any GPs in attendance at any of the sessions I was there at. I was there probably 3/4 of the sessions on annual leave for the last lot, but I'm not aware of any attendance, although they are aware of the consultation because we advertised it within GP surgeries, etc. We did have leads from within primary care in attendance, however. Lisa Milligan and Ruth came along and attended.
Okay, thank you. Any further questions? Okay, thank you very much.
Bob,
Beth,
Beth,
you always
sorry.
do that to me, Beth. Thank you. I'm just about to move on. Thank you, Beth.
No, it wasn't so much a question, it was just a comment. And I don't know about my colleagues around the table, but I was quite astounded by the numbers that have been just discussed there. I mean, I know we're quite good at consultation, and I don't think we appreciate how good Perth and Kinross are at that. Having worked in another local partnership before I retired, it is quite astounding, particularly when you've got the rural impact of how much is actually going on. And I think we really should note that those numbers are quite amazing. So thank you. I'm quite impressed. So I just wanted to note that.
Thank you.
Just say they're not exaggerated. They're actual factual.
Yeah, I think you made that clear, Ian. Bernie, final comment on this, and then Jackie wants to round off.
Okay, sorry, thank you. It was just to check that this, in relation to the strategic plan group and the meeting for the 16th of August, was purely to do with staff. It wasn't about the communication with the public, because I certainly know the events that were held, and I attended the one in my own local area, and I know that other members of Carers Voice attended in the other areas, and a huge amount of work that went in for the staff that were there. But I have to say that certainly in my area, for the whole event, there was myself and 2 other people that came, which must have been soul destroying for the number of staff that had turned out, and it was there in the evening. But the feedback also from my other colleagues who went in the other areas, they said that the turnout from the public was extremely poor. And so I just wanted to check, when you're saying the numbers, that's obviously staff, which is great, but it certainly wasn't the information that came back to us. And I certainly know from the event that I went to in Blairgowrie. So I'm just a bit confused about that. Thanks.
Then there's 50 staff came to the workforce. Yeah. The workforce event, but the locality events, that's numbers of people. But you have to remember there was 6 sessions in each locality, so they might not have been at your one specifically, but there were in other ones. So we didn't, I mean, I suppose relatively speaking, you weren't getting large numbers of people, but the people that did come into those locality events, the feedback that they gave was really high quality. So it was people who were really very involved in services generally. So, and it's why we ran them the way we ran them, in afternoon and evenings and over several days, to try and capture as many people as possible. We kind of mugged people in the streets and did things like that as well, as opposed to sitting in sessions too. So we used all sorts of forums to try and get people to contribute to that. So yeah, so collectively that is the numbers of actual members of the community that attended. The workforce didn't tend to come to those, other than us that were facilitating at the events, and that sometimes did outnumber people who attended.
Thank you. Jackie, do you want to finish off, make whatever comment you want?
Yes, thank you very much, Bob. And I suppose in terms of the detail of how people have contributed in the numbers, we'll bring that forward in a covering report along with the refreshed strategic commissioning plan in due course. So I think a lot of that detail will be in there, but it's been really helpful to have the update as to where we are now with things, and also to hear the voice of staff directly at the IJB. So I really thank you for that, Ian, and your role as co-chair of the strategic planning group. And that there'll be further opportunity to comment both next week and then at future events. But I also just want to say, pick up on Sally's point about if there are gaps, please, if you may not have had an opportunity to speak at this meeting around that, but please feed it back to myself and Zoe or Ian, in fact, if there are gaps there, because we need to fill that if we possibly can. Thanks.
Thank you very much indeed, and we note that update. Thanks, both of you. Very helpful indeed. That now takes on to 8, audit and performance, and 8.1, audit and performance committee update. Beth Hamilton.
I've got to follow Ian.
You're on there, Beth.
Oh.
Practicing yesterday.
Thank you very much. This is just a quick verbal report. We had our Audit and Performance Committee meeting on Monday of this week, so we haven't got the minutes written up. So this is just a quick run through the main issues of the meeting. We opened with the finance element of the Audit and Performance, and we had a report around the current challenges around finances, and we're projecting an overspend of 2.465 million at the end of 23-24, but there's a lot of discussion and evidence working on the actions that are being taken to mitigate that, and these were welcomed by the committee. We went through key strategic performance, and we highlighted in that we're now looking at a slight difference in the way things are reported. Historically, the data was coming from our national bodies, and it was historical data. It was up to 6 months behind. So we're also now looking at KPIs that are locally produced, and they're giving us more recent data. I think the challenge there is the comparators are particularly within Tayside and across the different areas. We don't have the same richness with our peer group, if you like, which are areas that are similar geographically in numbers, but we will be having them as they come through, so we'll have that comparator. So I think that's going to be beneficial for us in monitoring how we're performing along the way. And we also talked on the key strategic performance around the transformation work that's happening to try and work in and tie in with the mitigation around the funding. So that was good. Moving on with governance and assurance, we looked at the risk management, and risk exposure continues to improve. And we welcomed the fact that there was now a risk management agenda around mental health services, which we were clear on, and the strategic risk that we referred to earlier, which is shared across all of the partners within the strategic area of risk management. We went through the partnership improvement plan, and there was considerable progress on that as well, and we've completed 10 actions, and these actions are still within the plan, but they're clearly highlighted as being actioned and give us an indicator of how we're progressing. We then went on to the clinical and care governance element. That took us through the performance on our care services, and we talked about the report that goes to the scrutiny group within the council and goes up to the care governance committee of NHS Tayside. Just while I remember, Councillor Stewart, you had raised some issues about the chairmanship of the care governance of NHS Tayside being chaired by myself, as well as the Audit and Performance Committee here. I've taken advice from both Council and NHS Tayside, and both legal sides have told me I've got a different role in each area, so it's quite acceptable for me to do that. So we made sure that was okay. The report that came to the care governance group from Perth and Kinross, we had a substantial performance and assurance around it was granted by the health board after a lot of debate. If you can, the debate goes around whether we can have a substantial because you can't get any higher. But that debate continues around what are we assuring? Is it the processes or is it the outcomes? But if we're looking at the processes and how we're doing within Perth and Kinross, what we can see is we've got substantial assurance that we've got lots of processes, that we're doing the right things, and we've got processes that if something starts to go awry, we'll be able to pick it up quickly and deal with it. So that was a major impact and the major reason why it was substantial. The audit programme, we didn't have the chance to go over the audit programme at this meeting as the auditor was on annual leave, but we'll hope to pick up that because I think there's some issues that I'm keen to see how that's progressing, because there's particular areas in the audit programme that I'm keen that we hear about, particularly about third sector for the commission services, etc., that we need to have a look at and a bit of an understanding how it's progressing. So it was a very positive meeting. I think there was a lot of good discussion. I don't think anybody left feeling they were missed any points, but I'm happy to take any questions from anybody present.
Thank you. Questions for Beth Hamilton?
Nope. Okay.
Okay, thank you. Therefore, we now move on to 8.2, which is Beth, Donna and Phil.
Oh, Beth, Donna and Phil. It sounds like a pop group. Sorry, that shows I'm the baby boomer of pop group. Well, it is a bit about Beth, Donna and Phil. Phil produced this and I'm going to read it and Donna's behind it all. So I'm the lead singer. So the Audit and Performance Committee Annual Report 22-23. This report presented today, Appendix 1, is the first annual report from IGB's Audit and Performance Committee. The annual report provides the IGB with a summary of the conclusions from the work of Audit and Performance Committee during the year 22-23. It sets out how the committee provides the independence, questioning and thoroughness across a wide range of internal control, governance, finance and performance related matters. Some of the specific work carried out during the year is detailed in the annual report. This includes an update on strategic risk at each meeting, performance reports also at each meeting, approval of the annual performance report in September 2022, the partnership improvement plan to show audit recommendations progress, finance reports providing financial performance information, and the approval of audited annual accounts in September 2022. A conclusion is provided at the end of the report where I and the committee state that we're satisfied that the work of the Audit and Performance Committee as detailed in the annual report has allowed it to perform its delegated duties and also to fulfil its remit as detailed in the terms of reference. I confirm that there is no significant issues to raise to the IGB arising from the work in 22-23. I would like to thank committee members for their work, commitment and dedication over the past year. It's not an easy task to be a committee member on top of the work that being an IGB member brings. I would also like to thank committee services too for the work they do in preparing each audit and performance meeting as well as the IGB meetings. The committee are asked to note today the annual report as well as the level of assurance provided and acknowledge the work of the Audit and Performance Committee. Thank you.
Thank you very much indeed, Beth. Any questions? Stunned into silence. So we're sounds as though we're happy to note the report and levels of assurance as set out on page 5 and acknowledges the work of the Audit and Performance Committee members. Thank you so much indeed. I know how much hard work has gone into this.
Thank you.
Thank you. That now takes us on to governance and IGB direction policy. Verbal update by the Chief Officer.
Thank you very much, Chair. This is just a very brief update because we have in our forward plan an agreement to bring forward or bring back to the IGB an addendum to the IGB direction policy. The directions policy was approved in August 2022 and there was an additional requirement to set out the particular directions that arise from the lead partner arrangements. I think it's safe to say that our understanding and our shared understanding across the IGB here, but across the other two IGBs as well, has deepened over the last year. And each of the 3 IGBs have an approved directions policy. And we've got clarity now that the lead partner arrangement sits with the Chief Officer and doesn't sit with the individual integration joint boards. So, for example, in terms of the delegation of through the integration scheme of strategic planning for mental health services, that's to each of the IGBs and not to Perth and Kinross, although I, as the Perth and Kinross Chief Officer, hold lead partner responsibilities. You wouldn't really dream this up, would you? But so I think we're clear that an addendum setting out what our directions policy would be in those circumstances is perhaps no longer required, and what is required is coordination by the lead partner Chief Officer, coordination in terms of reporting to the IGBs and consistency of recommendations and consistency in terms of framing of directions. So it's really just to provide that update to the IGB.
Thank you. That's most helpful, actually. Thank you. Any questions for Jackie on this?
What happens if there's a conflict with the 3 IGBs and their direction? Who has final? Because you could be 3 IGBs trying to put a direction into the lead partners that's in conflict.
I suppose the tactful answer to that question would be that I think it's really incumbent on that Chief Officer with the lead partner arrangements to ensure that you're working across with the Chief Officer group, as in the 3 Chief Officers, their management teams and the IGB membership, to ensure we don't get to that position. So it's about working that through, but it's also, and it has to be in terms of making any direction to either NHSA side or to the council or to both, that can be deliverable as well. So there's a whole series of activity that I think has to go on before you come to the point of issuing a direction, and I think that's where the challenge and the skill will lie.
Thank you. Thank you, Jackie. And Sheila McCall.
It's just a fairly quick question, Jackie. Occasionally, things, as you know, get approved at Perth and Kinross Council, and then the delivery of that sits with the Health and Social Care Partnership. I'm particularly interested in the approval that was, or the motion that was passed at Perth and Kinross Council around becoming part of the fast track cities to end HIV. And I understand that Dundee is the lead partner, but the Public Health Committee of the NHS board recently, they weren't even aware that Perth had signed up to this. And so I'm just wondering, how do we make sure that somebody in the Health and Social Care Partnership for Perth and Kinross has some link into what's happening, and that it isn't just developed for Dundee?
I think that's a very good question, and it would apply to any of those services that are delegated, which used to be called hosted services. If we're thinking about prisoner healthcare or podiatry that we hold, there's something that needs to be strengthened is the reporting back into each of the IJBs on those services, and I think we've recognised that in our clinical and care governance arrangements and are beginning to share that across. But there's something about the exposure of what's happening in those services to back into the IJBs. There's a bit of work to be done there, I think, Sheila. Yeah.
Chair, if I can come back in quickly, I think it's quite important because these were approved by full council, and therefore somehow we've got to think as well as how do you report back to full council that these are progressing and how they're progressing. And the same will go for the WHO older persons approach. So it's just joining up those dots and making sure that we all know what's going on. Thank you. Thank you, Chair.
It's okay. And in fact, all of the IJB chief officers attend, or representatives attend, the Public Health Committee, so they all have an opportunity to feed on what they're doing at an individual IJB, and some of that will be informed by their councils. So we just have to keep working at that. Thank you. I don't see any other questions on this, so thank you very much for that helpful update, Jackie. And we now move on to item 10 for information. And 10.1 is the annual performance report itself, 22-23. I don't think we need any further input into this, but I think probably we're just happy to take any questions that people may have. I've got Sandra Auld.
Thank you very much, Chair. I'm not going to put my camera on. I had to step out for 2 minutes and then got caught in a complete storm, so I am dripping wet. So I'm going to spare you. I'm going to spare you those images. I thank you very much for the annual report, which I have scanned through. I haven't read it in any great detail, but I was very interested by the dental section contained within it. And Ian and I have been supporting a service user over the past number of months with a dental issue which hasn't been able to be resolved satisfactorily to their satisfaction, certainly at all. And it struck us that we haven't heard very much at all as an IJB from the dental side of practice. And I wondered if it was something that might be useful as a presentation to update us on the state of dentistry within Perth and Kinross. So that's one comment, I suppose, comment stroke question.
Sandra, do you want Zoe or Chris to just address that first of all, then move on to your next point?
Yeah, that would be super. Thank you very much.
It sounds like an entirely sensible idea to have somebody come and present on dentistry in Perth and Kinross. It's come up as issues at different periods of time, so yes, I'm sure we can invite. I think Jackie wants to come in.
Jackie?
But also just to be mindful that it's the public dental service that's delegated to Perth and Kinross IJB. It's not all dental services, so we'd have to just be very mindful of that.
Thank you.
Can I maybe just come in, Bob? Beth, just to say that.
Is that on the same point?
Yes, it's just to support what Jackie's just said and to say that the dental health services are part of the primary care. strategy that they're working on, and that's one of the reasons why there's been a delay, because the original version was just about medical service, GP services. So they're now going back, and there is an acknowledgement there's a lot of work being done around dental services, but I think the public dental services are part of here.
Okay, thank you very much. Your second point, Sandra.
Thank you. Throughout the report, there are references and examples and quotations from Care Opinion, which is a service, inverted commas, that I've used personally and find really useful. And at the reference group, over the last couple of months, we had a presentation from Care Opinion. And a question that was asked, and I'm also aware it was part of the presentation that I wasn't able to attend, that Tommy Whitelaw did also. So I'm aware that the other board members have seen this as well. But it struck us at the reference group that it was almost entirely positive feedback, and it's hard to comprehend that there appears almost to be no negative feedback at all, and in some ways that almost devalues the purpose when it seems so entirely one-sided, as it were. And so I just wonder if that's something that could be I don't know, examined a little bit and taken on board, because, as I say, it doesn't seem to be, in that case, then an accurate reflection of reality, really. Thank you.
As I remember from that presentation, in fact, I think the many letters that are critical are often there's reflections of both positive things, but also of things that needed to be changed or strengthened. And I believe the moderation in that seemed to be fine to me, but perhaps others may have a view on that. Who would speak on that?
Happy to comment, Chair.
Chris.
Yes, thanks very much for the question. Within the annual performance report at table 2, there's some data that has been collected in respect to our internal survey, and that balances the comparison to questions which are asked nationally every 2 years in respect to the health and care experience survey. So there are to this point there have been 2 approaches inclusive of the Care Opinion, which is growing in terms of the amount of feedback that's being received there. So as we move forward, we will make an assessment of the approaches that we take to gather feedback, and take on board the comments that Sandra's has made.
Okay.
Thank you very much.
Thank you, Sandra. David Illingworth, thank you.
Great, thank you. This report came to us on the audit committee back in July, and I'm basically going to repeat what Beth and I both said then. We appreciated very much that it's much shorter than previous years. It's reduced by 91 pages, 58 pages. We liked the fact that it was well written and very clear. Like Sandra, we were slightly suspicious that all the stories seemed to be great news stories, apart from, but those are the comments we had made back in July. So.
Okay, thank you. I must say I greatly welcome the shorter report. I have to say it's quite a hefty document to get through. It's quite detailed, but I greatly welcomed it. Okay, thank you. There are no more questions on this, and let's comment. Zoe, do you want to say something? And then I'll move on.
Bob, is it okay just to comment?
Yes,
it's just to say that care opinions, just as Chris is talking about, just one method of gathering feedback, and we do use that survey, but we also collate feedback on every single commission service that we have, and we have an annual report that will be coming here in due course, but we annually report on every service, so we gather feedback that way. But the other thing I would suggest is, just from the learning of the consultation process, was that we did hear negative stories during that consultation process, and it was hugely valuable because we were able to target interventions in very specific cases. And my sense with that is that we need to continue to engage on a locality basis, on a regular basis, sort of consultation clinics, something along those lines, with people such as myself and others who are involved in operational delivery that can understand better some of the issues that people do face. So I think Sandra's right to raise that care opinion is largely positive, and that's great. But that's what the opinion is that has come through that certainly form of consultation. But it's one of a few, and it's an area that we can continue to improve upon, I would suggest.
Yeah, thank you very much. And I think the numbers are the fifth largest number of respondents in UK. Is that right, Jackie? For care opinion, and it's great. A lot of work to be done on following on from that. So thank you very much indeed. That now takes me to 10.2 integration joint board reporting forward planner for your information. And then we have the future meeting dates and the future IJB development sessions. Now you'll have seen an email that came out from Scott Henry earlier on today that makes some amendments to that for your information, and importantly includes the vital budgetary development sessions and the actual change date for budget approval itself. Thank you. Thank you. You've all got that, so there's no shortage of things there. As this is my last meeting as chair, I just want to thank everyone that I've worked with over this period of time. I'd particularly like to thank my vice chair for supporting me, and indeed for Jackie Pepper as well, in terms of their support to me, and indeed the corporate support team as well for all the work they've done to help us, to certainly help me and us over the last 2 years. So thank you very much indeed. I've greatly appreciated that, Scott. Thank you. And with that, I don't think we've any more questions. Thank you. Meeting closed. Bye-bye.
No.
Oh.
But you can go on mute though. I think it's a shame that you're not here in person, Bob, because we as you know, people's appreciation, they're eager to appreciate the dedication and the support that you've given to all of us around this table. And just as a reminder, I think your first IJB meeting in Perth and Kinross was back in April 2019. So you have a long history here, not just in the role of chair. You're a member from April 2019, vice chair from November 2019, and then took on the role of chair from September 2021. And we're actually really grateful to know that you're going to continue to be a member of the IJB, just given that level of knowledge and understanding and experience that you bring to that. So we're pleased that you're returning in October to become a member of the IJB, and I know you're quite looking forward to that. But I'm going to mention something why I think you're looking forward to that. But I suppose in terms of that time scale, and think of everything that's happened in those years, you know, not least a COVID crisis and a pandemic response, and everything that was happening in health and social care, and the remobilisation of those services. So you've seen this IJB through probably the most difficult of times that could ever have been imagined. and we're very grateful. I know I am, and I know I'm speaking for many people here, and certainly my management team, that your focus on staff well-being, and their welfare and well-being, we really appreciate that, and we hear that loud and clear in many of your contributions, and how you support us. Also, your strong focus on human rights. And you bring the public health dimension. We've been speaking about that today. That sense of we need to think more broadly than the IJB, beyond that in a strategic way, looking at our community planning and the assets that the community brings to the challenges that the IJB is trying to strategically plan for. You've also seen 2 chief officers in that tenure, I think, as well. So there was Gordon and then myself, and I know that we've both benefited from your wise counsel and support and all that you've done to assist us, and we really do know that you care for our well-being, and that's sincere. And I was thinking, your comments about returning to the back benches, and just we spent a whole day at the same table yesterday at the partnership conference for NHS Tayside, and I'm reflecting on the power of the question, Bob, and you did it beautifully yesterday in the way that you assisted us to focus on actually those what really matters, the right things, the big ticket items, helping us to think big, be bold, and take that longer term view. You did that beautifully yesterday. So I'm looking for the power. I'm looking to you in terms of the powerful questions that you can ask us as an IJB, as a member, as we move forward, and looking forward to continuing to work with you in that role. So, and I'm sure everybody would want to send their appreciation to you as well. Thank you.
Well, thank you very much indeed, Jackie. And as I say, there's no such thing as retirement. You've always got plenty of work to do, so I'll be happily to join the rest of the member group, and I really welcome Jackie to take us to the next stage. Jackie Jensen to take us to the next stage as part of the vice chair and part of that senior team, leading on our governance arrangements. So I think it's great. So we're not losing anything, we're just gaining more experience. Thank you. Thank you very much indeed all, and thank you for those kind words. I really do appreciate it.